please raise your right hand and say, so help me God.
So help me God.
You're welcome to be seated. Mr. Green,
Yes, thank you, my Lord. My Lord, before I begin with Professor Beale's evidence in chief, could I raise the question of whether he should be filmed in the proceedings? Professor Beale has expressed the view that he would prefer not to be filmed. It will be broadcast for the world to see. The witness is converted from a witness into an actor once he is filmed. And that is, with respect, my Lord, not fair to the witness. No witness should have to endure the prospect and thought that his performance will be broadcast to the world at large. It's not a question of transparency, my Lord, because any party, any member of the public who wishes to watch these proceedings is free to come to court and watch the proceedings. It is an open court. But what the member of the public is not entitled to, my Lord, is to demand that the proceedings be broadcast so that they can, from the convenience of their lounge, watch the proceedings. So, my Lord, we would ask your Lordship to confirm that Professor Beale's evidence cannot be filmed. But of course, as I've said, he can be named in the media reports that are given. So, my Lord, we'd ask a ruling from your Lordship that Professor Beale's evidence should not be filmed. The photographer that is in court is aware that we will seek this ruling from your Lordship. We did tell him before the proceedings stopped. So, Lordship, I ask for such a ruling.
can I hear the side of the state in this regard? What is your attitude?
Well, it's neither here nor there for the state. The thing is just, like my learned friend said, it is open proceedings, and there has been broadcast of the state, portions of the state's case. So I don't see the difference between the state witness and the accused in that matter. So, but we are in the court.
Mr. Green, the order that I was requested to read right at the beginning, does it not address the issue?
Yes, my Lord, with respect, it does.
Does it?
And any witness, including the accused who elects to give evidence as a witness, is entitled to ask not to be filmed. That's why, my Lord, and my learned friend is quite correct, that all witnesses are entitled to the same treatment. So just as the state's witnesses were entitled not to be filmed, so too the defense witnesses, including the accused, is entitled not to be filmed. Otherwise, the playing field is slightly off.
Did the order also include the accused?
It includes
not specifically exclude the accused.
No, it doesn't, my Lord. It doesn't specifically exclude. I stand corrected, but it does not.
Well, to the extent that I may have to amend the order, as long as it's not a live broadcast, as long as they may take whatever is relevant for purpose of showing highlights, as it were, of the proceedings.
My Lord, it is that Professor Beale does not want. He does not want to be filmed giving evidence at all. The written press, of course, is at large to report as they will and as they have, and we accept that they can name Professor Beale, unlike the other witnesses. But the filming of Professor Beale should not take place. Lord, if there is to be a via media, if I may suggest, the cameraman can film me. I don't have any aspirations to be broadcast, but if there is some via media, that can happen. But Professor Beale is entitled to give his evidence without the concern that he has of being broadcast. So, with respect, my Lord, your Lordship ought to grant the ruling. Otherwise, there is a disparity in the playing field of the state's witnesses and the defense witnesses.
I was surprised by this because I didn't have time to reflect on this. I thought we had addressed this right at the beginning. At the same time, I don't want the proceedings to be tainted by unfairness. Having said that, to the extent that I may have to amend the order. I'm saying what I would forbid is live broadcast. Live broadcast. That's what I would forbid. But I can't see why portions of this evidence can be broadcast.
The order in terms excludes live broadcasting. It was never permitted.
Yes.
So your Lordship, by allowing highlights packages, is the very thing that the order permits. And it is that which the other witnesses who have declined to be filmed have been entitled to. They are not filmed. They were not filmed. Your Lordship, by allowing highlights of Professor Beale to be filmed and broadcasted, is with respect creating a disparity in the environment and the field on which witnesses give evidence.
May I say something?
No, you may not. You've got cancer. So let me adjourn for a moment and reflect.
As your
I
Lordship,
wish you
please.
had approached me a little bit earlier, so that we can then put this to rest. But then it is the choice that you have to make. Let's take a very brief adjournment. Let me reflect about it.
I mean, that is your Lordship.
All right.
Back on the clock. Well, my answer is simple. All shall be equal before the law. Now that you're in the witness stand, I grant your wish. The production team may not flee your proceedings. But the situation is different when you are in the dock. As I said from the beginning, in the dock they can film me as much as they want to. Thank you.
Thank you, my Lord.
As your Lordship pleases, we're indebted and of course by your ruling. My Lord, let me, if I may, just deal with some introductory aspects with the witness and for your Lordship. Professor Beale, you wear hearing aids, is that correct?
That's correct.
Yes. Could I then just raise with you, if you do not hear a question correctly from myself or from His Lordship or the assessors or Ms. LaRue, will you please say so? That you've not heard it, and whoever is asking will speak up. The next thing, your hearing aids are adjusted by using your telephone, is that correct?
If necessary, yes.
Yes. So if you take your telephone out, you're adjusting your hearing aids, you're not checking your Facebook profile, is that correct?
No.
Yes. Now, Professor Beale, I've raised with you before you got in the witness box, could I just remind you, we have a lot to get through today. If you are tired, or if you feel your concentration is waning for a moment, would you please raise that with His Lordship, and I'm sure that we can take a short adjournment for you to stretch your legs and regain your strength. Would you please bear that in mind?
Thank you.
Yes. Then, again, just on matters of logistics, you're going to be referred to documents when you give your evidence. If you are unable to locate the document, please do not worry. Just indicate that you can't find it, and Mr. Boyser or Ms. Albertser will come to the witness box and guide you to the correct document. Then the last thing, Professor Beale, is, as you have seen with other witnesses, the microphone in front of you only records. It does not amplify. So please speak as loudly as you can when you answer your questions, so that everybody can hear.
Yes, my Lord.
My Lord, for your Lordship's benefit and for the assessor's benefit, could I give your Lordship the roadmap of Professor Beale's evidence, because it is fairly long. Lord, the first part of Professor Beale's evidence will deal with his background, his qualifications, and his experience. My Lord, and for that part of the evidence which should not be contentious, we have prepared a document to assist your Lordship, the assessors, and Professor Beale. My Lord, the second part of Professor Beale's evidence will then deal with his financial position and the investment in the Tannenbaum scheme, where your Lordship has the admission that an amount of 1.504 million rand was lost. Lord, then the third part of his evidence will deal with the Syed case. The fourth part of his evidence will deal with the Tubes case. And the fifth part of his evidence will deal with the Straydon case. Lord, my plan, if the timing goes as I hope it will, is to complete the qualifications and experience, the finance, Syed, and at least the significant part of the Tubes case today. It may be necessary to complete Tubes tomorrow and then deal with Straydon tomorrow.
Can I ask something?
Yes, my Lord.
This qualification and experience, is it contagious?
My Lord, it's not, but it is relevant, we would submit, because your Lordship has heard the evidence of most of the medical people who have gotten into the box to say that when it comes to questions of medical judgment, experience is important. So we would like to lead that evidence, my Lord.
By all means.
Yes. All right. Professor Beale, let's then move on, if we may, to the first part of your evidence, and that's your training and your experience. My Lord, as I said, we've prepared a document. May I beg leave to hand it up? It will be ZZP, Zulu Zulu Peter, my Lord.
I take it there's no objection.
No objection, my lord.
Zulu Zulu Peter received
As your Lordship pleases.
in court.
Now, Professor Beale, the exhibit ZZP is, you've seen this document before, and you have read it. Can you confirm that it is correct?
It is correct, my Lord.
Could we then just go through some of the parts, and I'll ask you to elaborate and highlight on them. My Lord, with my learned friend's leave, I will lead Professor Beale on these parts. If I overstep the mark, she'll of course object and flag that I should not leave. Professor Beale, you're born in 1946 and you're currently 77 years old. Is that
Correct.
Yes. And then in paragraph 1, we have also set out your age when the various surgical procedures which you carried out were performed. So with Zayan, you were 73, with Alyssa, you were 69, and with Ethan, you were 65. That's just a matter of mathematics.
Correct.
Yes. In paragraph 3, you completed your Bachelor of Medicine and Bachelor of Surgery degrees at the University of Pretoria in 1965.
That's correct.
Yes. And in paragraph 5, you start dealing with your internship, which commenced in 1971. And you were an intern at what is now the Steve Biko Hospital, and you were then, in the second half of 71, an intern at the Baragwana Hospital.
Correct.
And in 1972, you were a senior intern at the Steve Biko Hospital, and in the second 6 months of 72, you were a senior house officer in the surgery and neurosurgery departments. Is that
Correct.
Yes. And Professor Beale, can we just pause there? The system of internship back in the early 70s when you did it is slightly different to what it is today. Is that correct?
I would think so.
In 1973, you took up the position of Registrar of General Surgery at Pretoria University, and you rotated between the Steve Biko and the Califon hospitals.
Correct.
Could you just tell His Lordship the position of a registrar? What is that? It's, as in rank, what are you doing as a registrar?
As a registrar, you're a trainee in the specialist of surgery. You run the surgical ward and organize surgical schedules and do surgeries both under guidance and also on your own. And you have working under you interns and senior interns. And you have students associated or allocated to your registrar group for rotating periods of time. And, you know, amongst others, you teach them in that time.
So,
And
sorry, Professor Beale, so you're both being taught to be a specialist and you're teaching others as well?
it certainly was like that in my day.
Yes. And that, you say in paragraph 8, that took you from 1973 to 1977, is that correct?
Correct.
Yes, and then over the page, of paragraph 9, you deal with certain exams that you wrote, and you say you wrote the College of Medicine exam for surgeons in South Africa. So you became a fellow of the college in South Africa. You also completed an M.Med degree at Pretoria University, and you completed the Scottish degree so that you could become a fellow of the Royal College of Surgeons of Edinburgh. Is that correct?
Correct, my lord.
And once you had completed those, you were then a specialist surgeon.
Correct.
You then in paragraph 10 say that once you had been completed your training as a surgeon, you joined the University of the Free State as a consultant. A consultant is somebody who, as it were, trains the registrars.
Correct.
In paragraph 11, you say in July 1979 you joined the University of the Witwatersrand and you were a senior registrar in paediatric surgery.
Correct.
Can you just explain to His Lordship, you were at the Free State University, you were a consultant who trained registrars. Now, when you go back to Wits, you've gone, as it were, backwards because you're a registrar. Can you explain how that works?
You're now a trainee again. Doesn't mean your status changes really, but you then, as it were, senior registrar or senior resident, as they would call you in the US, and you're a trainee in pediatric surgery for a fellowship time, which is 2 years in all, to be able to register as a pediatric surgeon.
So you're training as a subspecialist, is that right?
Yes, a super specialist, put it that way.
You refer in that paragraph to performing miss and fund application operations. Is your time as a pediatric surgery registrar in 1979 the first time that you performed miss and fund applications?
Yes, my lord.
Yes. And were they done open or laparoscopically?
In that time it was open. Laparoscopic surgery didn't exist.
Then in paragraph 12, you refer to the time, the 6 months that you spent at the Children's Hospital in Seattle in the United States. That time that you spent in the US at the Children's Hospital in Seattle, did that count towards your registrar time for pediatric surgery?
Yes, sir.
Paragraph 13, you then say from July 1981 you returned to Wits and you were employed as a junior consultant in pediatric surgery on the Wits circuit. And you give the current names of the hospitals that are there. Is that correct?
Correct, my lord.
Would you just tell His Lordship what your surgical involvement was when you joined as a junior consultant?
During this time I did mainly children's surgery, but was also included in the Wits transplant unit doing renal transplants in children and adults.
So Professor Beale, just raise your voice, it's dropping off a little.
Sorry. Saying I did mainly children's surgery, and as a junior consultant carried the bulk of the surgical responsibilities. I hadn't been back for long when the head of department actually resigned and went into private practice. I also became a member of the Wits transplant unit, doing renal transplants in children and adults. And as a pediatric surgeon, I did the bulk of the pediatric recipient operations. I remained a member of the transplant unit for 30 years, during which I did approximately 1,500 renal transplants, of which 360 were children, the smallest weighing just over 8 kilograms.
Then, Professor Beale, in the next couple of paragraphs, you just recount your progress through the ranks, as it were. In 1983, you became a senior consultant. In 1992, you became a principal specialist. And in 2002, you were appointed as an adjunct professor in pediatric surgery. Is that correct?
Correct, my lord.
Then again, just recounting what happened, paragraph 18, from December 2004 to September 2013, you were the chief specialist in the Department of Pediatric Surgery at Baele.
Correct, my lord.
You set it out in paragraphs 19 and 20 what you did as the head of the department. Just give His Lordship, if you will, a short version of what you did as the head of the department.
My lord, it was a matter of heading and administering the Department of Pediatric Surgery, and mainly in what was New Johannesburg Hospital and became the Charlotte McCheki Hospital. And but Baragwanath and Rahima Musa hospitals were also part of the department, and I had junior people working mainly in those two parts of the department. I was still involved in doing surgeries on quite a major scale, and I had registrars and rotating general surgery registrars doing their pediatric rotation, and registrars who were specializing in pediatric surgery, and visiting registrars who'd always in the past gone to Cape Town, to the Red Cross Children's Hospital, started coming to Johannesburg to get their experience and training in pediatric surgery. I organized the academic program for the Department of Pediatric Surgery. This involved meetings both at Baragwanath Hospital and at Johannesburg Hospital.
I think that's given His Lordship a sense of what the head of department does.
Yeah.
In paragraph 21, you deal with your appointment as the examiner at the College of Medicine for pediatric surgeons. Is that as it were, the final exam that a pediatric surgeon would have to sit?
Yes, it's a fellowship exam in pediatric surgery. I've become the president of the Pediatric Surgery Association, and when the fellowship in pediatric surgery was established as a separate fellowship, I was briefly the chairman of the College of Pediatric Surgeons until my tenure was over.
Then you in paragraph 22, deal with the papers that you've presented both locally and internationally, with 55 to the local South African Association of Pediatric Surgeons and 12 to international congresses.
Correct.
We needn't pause too much there. In 2007, you deal with the award for excellence in healthcare that was given to you by the HPCSA. And then in paragraph 24, you deal with something called SurgiKids. Would you just explain to His Lordship what SurgiKids was?
My Lord, I was frustrated by the fact that we were doing 4 times the work turnover that they did in Cape Town, where they had a specific department for collecting funds for the Red Cross Children's Hospital, and they had an absolute extravagance of facilities, and we were getting nothing, and corporates in Johannesburg were donating to Red Cross in Cape Town. And so I initiated a fundraising program, and the first one I called SurgiKids, and it was registered at the Wits Foundation, and it started off by organizing functions where we got a limited amount, 80 or 90,000, rand at a time, and subsequently I also negotiated with Vodacom at the time to refurbish and rebuild the ward at Baragwanath Hospital, Ward 32. And it was in a shocking state. And to the credit of Vodacom, they came and did it with such enthusiasm and dedication, to the tune of 1.9 million at the time. And their refurbishment of that ward is still as it was, and made a huge difference in the facilities for care of children in that ward.
Professor Beale, then in paragraph 25, you deal with the progression of surgery kids as it was, with reference to Mr. George Mazarakis and carte blanche. Could you just briefly tell His Lordship how surgery kids changes to the Make a Difference program?
It was really a huge stroke of good fortune that I was given an introduction to Mr. George Mazarakis, who at that time was the director of the carte blanche program, and he actually came to see me in my office at Johannesburg Hospital, and I told him about surgery kids and what the aim was, and we hope to generate funds to improve facilities and equipment. And he listened to this, and he said to me, just coincidentally, they were looking for a project for their 20th year birthday project, and he would be in touch with me. And within 2 days he had phoned me back and said they wanted to adopt that project, that fund, as their 20th year birthday fund. And I'm no longer involved, obviously, but it's been really a revelation and a huge success. The first 50 million they collected was spent on refurbishing in Baragwanath and Charlotte Mateki hospitals, and subsequently in hospitals, children's facilities all over the country, in Durban and in East London, and in Tygerberg in Stellenbosch, and everywhere except, in fact, Red Cross, where they already had everything they could possibly hope for.
And Professor Beale, you make the point in paragraph 25 at the end that the amount which has been raised through these efforts, which started out with surgery kits, is in the order of 400 million.
You know, when I last knew, and I think it's got to increase since that time.
Yes. And then in paragraph 26, you deal with the award that carte blanche had given to you. And then in paragraph 27, you deal with your involvement in the design of some of the features of the Mandela Children's Hospital. Just very briefly, could you tell His Lordship what part of the hospital were you involved with designing?
With the Nelson Mandela Hospital?
The Nelson Mandela Children's Hospital.
Well, you know, for instance, in insisting that they create a day ward, which they hadn't made provision for, because I pointed out that if they were going to do, they're hoping to generate funds from the private sector as well in that hospital, they would have to do day case surgery, and because that's the main way that one generates funds for in pediatric surgery.
Was your contribution related to the surgical aspects of the hospital?
Yeah, and also the ward arrangements, because they had designed that. It was designed by a gentleman called John Cook from London. He'd won the on a competition.
Take His Lordship to what it was that you designed.
Yeah. Well, I've got to say that the design was that every patient had their own cubicle and so on. And knowing, you know, the custom of our patients, that they were used to being in communal wards, and not in that sort of, and the fact that we don't have the ratio of nurses to patients that they do in first world countries, so they changed that.
I'm going to interrupt you just
Yes.
because you and I have discussed this. Your contribution was to get rid of the individual cubicles and to create community units. That was one of the things you did.
Yes.
Right, let's move on if we may. In 28, you deal with, or you go back in time to 1990, and you deal with the concept of limited private practice for remuneration for work outside the public sector. Can you just explain to His Lordship why that limited private practice, or REWAP scheme as it's known, why was that so important?
There was a demand in the private sector for pediatric surgery expertise. Some of the more senior pediatric surgeons had left the country, and I was being requested to attend to specialized patients in different places outside the hospital. And at that time it was actually not allowed. And I did it for about 9 months before I ever started charging any patients on medical aid rates.
So it satisfies a demand in the
Yes.
private sector for pediatric surgeons.
And
And
then-
of course, as you say in paragraph 29, it gives you an extra source of income.
It does. And then I actually had a meeting with the dean of the medical school at that time, Max Price, and the CEO of the Johannesburg Hospital, Dr. Joe Buerta, and they sat with their calculators, and I told them what hours I did where, and then they signed an authorization, and I was happy to say I was the first person ever to get authorization to do that.
In paragraph 30, you make the point about normal retirement age of it being 65, but you were granted a special dispensation to carry on working until you were 67, and you then retired in September 2013. Is that correct?
Correct.
When you retired, you continued with your private practice.
Correct.
Mr. Bill, you put away your experience document for now. Now I want to move on to what I said to His Lordship was the second part of your evidence, and that is your financial position. And I'm going to, when asking your questions, ask you to contrast 2009 and your current position today. You'll just bear that in mind. The state has suggested that you operated on the 3 children in this matter for your own financial gain, and that you did so because you had lost money in an investment scheme that's commonly known as the Tannenbaum scheme. What do you say to that?
No, they accuse me of operating for financial gain without indications. And
That was too soft for me. I could not have what you said. I'm going to ask you to put
Yes.
up the voice.
so they accuse me of operating on patients and doing surgeries not indicated for financial return. And all I can say is that is never, ever going to happen. So that accusation and charge I deny absolutely.
Yes. Now, you have admitted that you lost 1.504 million rand in the Tannenbaum scheme, and His Lordship has an admission to that effect. Could you tell His Lordship whether that is a significant or an insignificant loss to you in 2009, and whether it was ruinous to you, and what effect did it have on you, having lost 1.5 million rand?
Well, I was disappointed and I was angry, and I had reactive depression for a few months, and then I got over it and I took the advice of draw a line in the sand and move on. But in fact, it didn't make a substantial difference to my financial status at the time. I didn't lose anything. I didn't have to change my lifestyle. you know, the Tannenbaum scheme was forgotten, and I carried on as per normal.
Let's just go back to 2009 when the Tannenbaum loss eventuates, Professor Beale. At that stage you were still married to your wife. What do you estimate your joint estate was worth when the Tannenbaum loss arose?
No, at that time, I mean, our joint estate was eventually worth 40 million.
Yes, just
I
speak
didn't
up.
get that, my lord. I didn't hear that.
Speak up, Professor Beale.
The joint estate was eventually worth 40 million.
In 2009,
It's apart from fixed properties.
so over and above this.
Yes.
Yes. Well, let's look at the fixed properties that you had in 2009. Did you and your wife own a home?
We did
Which suburb was
in
it in?
River Club.
And is River Club, how would you describe the suburb?
It's a very nice suburb, and we had a lovely home actually.
Yes. And tell his lordship, was that house bonded at all?
No,
So it was paid up.
it was paid up. Yes.
Did you have a holiday home in 2009?
Yes, I had owned 50% of a holiday home, and I still own that 50%.
And where is that holiday home?
That's at an estate called San Lamia on the south coast.
And
Please start on the name of the place.
San Lamia, SANLAMWR.
Professor Beale, it shouldn't be contentious. San Lamia is a golfing estate on the KwaZulu-Natal south coast and is considered to be an upmarket estate. Is that correct?
Yes, it's a wonderful estate.
In 2009, you were, on your experience and work history that you've given, you would still have been employed at WITS as the head of department, and you would have had your limited private practice. Can you give his lordship some estimate of what your annual earnings were in 2009?
I think between 4 and 5 million rand a year.
You've referred to some investments that you had. Can you tell his lordship about the aircraft that you invested in?
You know, together with 2 other people, Charles Rowlandson and Michael Black, who was my brother-in-law, we bought and owned a Pilatus PC-12 aircraft, which was an 11-seater aircraft, and my share in that investment was 40%, and that aircraft was chartered out to various companies.
And Professor Beale, the price of aircraft, are they fixed in rands or in
dollars?
US dollars?
US dollars, yes.
I understand, please just tell his lordship if I'm wrong, aircraft, because of their dollar denomination, were good rand hedge investments. Is that right?
They were very good investments at the time.
Would you tell his lordship about your investment in the Linksfield Clinic?
Yes, I was invited to participate in the original plan of Linksfield Clinic, and together with a doctor's body, I signed a surety for the establishment of that clinic. And the head of that doctor's body, in fact, was an ear, nose and throat surgeon who went to Australia, and I think second was Ponkifera, an orthopedic surgeon. And what happened, somebody called, no, it doesn't matter, was the architect, and doctors are not necessarily good managers, and that clinic was sold first to Clinic Holdings, which became Netcare. And when Netcare took over the hospital, we were allocated shares. and in Netcare, and it was sort of something for nothing for a signature as somebody standing surety. So the value of that, I actually then redeemed those shares because they were not doing anything for a while, and it was shortly after the Tannenbaum fiasco. So, you know, redeeming 1.9 million for essentially for nothing helped me to get over and forget that.
Your investments, do you manage them yourself or do you have assistance with them?
No, I have a financial manager who is excellent, and she's been my financial manager, I think, for about 25 years.
And when you suffered the Tannenbaum loss, did you discuss that with your financial advisor?
Well, she was aware of it, yes.
Yes. And did she say to you after that loss that you were facing penury and financial hardship?
Not at all.
Do you still have the same financial advisor today?
I do,
Yes.
and I really appreciate her.
What does she tell you, or what has she told you about your current financial position?
She thinks my current financial position is very satisfactory, and I can enjoy a retirement and travel and do whatever I want.
You were divorced from your wife in 2020, is that correct?
January 2020, yes, sir.
And the joint estate was divided.
Correct.
Today, in 2024, what do you estimate the value of your estate is, excluding your ex-wife's?
Close to 20 million, my lord.
Do you receive a pension in addition to your investments?
I do. I receive a very good pension, thank you.
Can we just turn to the Tannenbaum scheme for a moment? And could you just give His Lordship some detail on this? Was the Tannenbaum scheme what is often referred to as a get-rich-quick scheme?
It wasn't supposed to be. I think some people did get rich quick. Other people lost money. 800 people participated in it, including the chairman of the Johannesburg Stock Exchange and other prominent business people.
Professor Beale, what was the return that you were offered on the investment in the Tannenbaum
It was
scheme?
a 15% annual return was supposedly what we were going to get.
And can you recall, back in 2008 and 2009, a 15% return, was that an extraordinarily high return or was it market related?
It was above market related return.
Just could you explain to His Lordship, Mr. Tannenbaum, what is he by profession?
He's a pharmacist. Can't remember what company he's related to.
And who are Mr. Darrell Lee and Mr. Dean Rees?
Two members of the legal profession, attorneys, and they administered this fund.
And the Tannenbaum scheme, as it's become known, what was it sold to you as? What were they going to do with your investment?
Well, it supposedly was to import raw materials for anti-ARVs, anti-AIDS retrovirals. And I'd been a AIDS activist at that time, but so it fitted in with that purpose. And that's why, you know, it was a lot of public-spirited people participated in that, and they were taken in by it. And it was, in fact, the biggest Ponzi scheme ever in South Africa, and yet nothing has ever been done about it.
Professor Beale, let's just move on if we can. Tell His Lordship, when did you first meet Mr. Darrell Lee, the attorney you referred to?
Now, Darrell Lee was a member of a group of us that had a Sunday morning tennis club. and he played together with us for many years, and then he left and rode fancy motorbikes, and we heard that he had become very wealthy and he was doing very well. And I ran into him again at the Motor Show South Africa with Jeremy Clarkson at the Dome in the north of Johannesburg. And SurgiKids was the beneficiary, supposedly, of the Motor Show Africa for 2 years in a row. And I had a presentation there, and there were images on TV screens throughout the dinner hall.
And just tell His Lordship about the donation that Mr. Lee made.
Yeah, Mr. Lee made a donation to SurgiKids, and he challenged others in the audience to better his donation.
Do you remember how much he donated to SurgiKids?
Well, I think it was 200,000 actually. And the total that I got that evening was in excess of 400,000, and it was donated directly, fortunately, to the Wits Foundation.
Now, Mr. Lee has made a substantial donation to SurgiKids. Did you... You asked him to dinner to say thank you, didn't you?
No, we invited himself anyway.
Tell His Lordship about what was discussed at
He came and he parked his Lamborghini outside, and he told us about the Tannenbaum scheme and suggested that we should participate. And in fact, we were persuaded to do so.
So it's at the dinner that the Tannenbaum scheme is, as it were, sold to.
Correct.
Professor Beale, can I just ask, are you still comfortable?
I'm absolutely fine, thank you.
Let's then move on, if we may, to the third chapter of your evidence, as it were, and that's Zion Sight. Now,
Yes, my lord.
His Lordship has heard about endoscopic surgery or laparoscopic surgery. And you have already in your evidence referred to misfundifications first being performed by you as an open surgery. Just on an open surgery, this shouldn't be contentious. That is where there is a large incision made in the patient's abdomen to gain access to those structures which are required to be accessed for the misfundification.
Correct, my lord.
Tell His Lordship, if you would, about your introduction to endoscopic surgery and your training that you could undergo in that regard whilst at Wits.
I wasn't the first person to convert to laparoscopic surgery. The worldwide, the greatest indication for laparoscopic intervention in children is anti-reflux surgery and mainly misfundification.
Sorry, Professor Beale, I must have asked the question very poorly.
Now I'm going to tell you now.
Tell His Lordship about the endoscopic surgery training laboratory.
Yes, in the surgery department, where I still have an office, there's a endosurgery training facility where you can, there are boxes where you can, and instruments, laparoscopic instruments, and where you practice endoscopic maneuvers like suturing and knot tying. And so I was able to spend quite a few hours there, and in fact there were reps from companies who assisted me with that, supplied the stitches. And
Professor Beale, what you've described, His Lordship and hopefully most people in court have seen on televisions, flight simulators, is what you've described a type of surgical simulator.
yes, ma'am.
Just generally describe to His Lordship what a surgeon does when performing laparoscopic surgery. How do you get instruments inside a patient? How do you see what's going on inside a patient?
Well, you've got to introduce ports through the abdominal wall, so you make small incisions. And the first one is made in the umbilicus in these cases. And you introduce a port into the peritoneal cavity. And it's airtight, so it's snug on the port. And through that port is a channel where you connect carbon dioxide from an insufflator at a certain pressure, and you distend the abdomen so that you create space inside the abdomen.
Professor Beale, can I pause there? You heard with other witnesses, I've said, let's try and put things in lawyer language. Insufflating and distending the abdomen, it's like blowing up a balloon to make space. Is that
Correct.
How do you see what's inside?
Well, there's a television screen that's conveniently placed just across the table, so you've got direct vision to instruments inside the abdomen on the television screen, and then the anatomy, obviously, intraperitoneal anatomy. So once one has placed your blown up the abdomen, you place a lens through that port. And in children mainly it's a little 5mm fiber optic
The lens is
lens.
a camera in lawyer speak.
Yes, yes. It's a fiber optic, but it's not a flexible, it's a rigid strap.
So you can see what's going on
Yes.
on the screen, and you then keep showing with your hands. You're manipulating with your hands. Are you showing His Lordship a manipulation of instruments with your hands?
Yeah, well, we hadn't got to a place where you then place other instruments into the abdomen through other incisions. When doing this fundoplication,
We'll come to the detail on Zayan, just generally.
yes,
laparoscopic
this
surgery.
is generally you.
I think you've given His Lordship the explanation. Can you tell His Lordship, has laparoscopic surgery gained popularity over the years?
It most certainly has, and it's become.
Why has it gained popularity?
Well, because it's far less invasive. It's people call it keyhole surgery, and it's done through small incisions that you put local anesthetic into after the procedure, and so the discomfort and pain is far less, and the recovery of the patient is far more rapid afterwards.
Tell His Lordship
And-
about scarring after
And there's far
laparoscopic
less
surgery.
scarring. There's small little incisions that become imperceptible with passage of time in most cases. And there's not a large skin incision and a large opening in the peritoneal cavity to get access so that you can see the organs in the abdomen.
On the question of seeing the organs, can you tell His Lordship what one of the benefits of laparoscopic surgery is in being able to see what's there?
Oh yes, it's beneficial in that the you've got the lens gives you light, so the illumination is superior to open surgery, and secondly you've got magnification, so the structures are magnified.
And if one were doing an open surgery, how would you achieve the magnification that you would otherwise just be able to do electronically on the laparoscopic surgery?
Well, if you're doing it open, you've got to direct overhead lights into the area. And certainly I, for the most of my career, used surgical magnifying loupes.
Loops is spelled L-O-U-P. Yes. is that
Yes.
right? Yes. Those are the things that sometimes we have seen people stick on the ends of their glasses.
Well, they're custom made with cones on the glass and custom made for the surgeon. And I'm happy to say I was the first surgeon in South Africa to acquire and use loops routinely.
Tell His Lordship, through your use of the training laboratory at WITS and through your experience in endoscopic surgery, do you consider that you acquired an adequate or an inadequate degree of proficiency in that surgery?
I had sufficient, I think, aptitude, and I acquired sufficient competence to do laparoscopic surgery.
Yes. And how did you keep up with developments in laparoscopic surgery?
Well, firstly, one attended a number of courses, of training courses in endoscopic surgery over a number of years, and secondly, by following journal publications with and interacting with colleagues and discussing techniques. And there were always representatives from companies who would come and demonstrate and show, improved instrumentation and so on.
Did being in an academic environment assist in keeping up to date with developments in laparoscopic surgery?
Yes, definitely. And the Carte Blanche Made a Difference campaign supplied us with the absolute whole range of updated endoscopic equipment.
You've mentioned courses that you attended. Now, Professor Beale, it's not a memory test here. You've given me those courses that you attended. Let me just go through them, and if you'll confirm to His Lordship that I have them correct. In March 1991, you attended a laparoscopic workshop at the Kenridge Hospital, which was presented by Professor Ron Hinder from the United States. Is that right?
Correct.
In July 1992, you attended a course in advanced endoscopic techniques at WITS, and it was presented by Dr. J. Peters from the
USC.
US.
Jonathan Peters from USC.
In August 1994, you attended the symposium on evolving application of pediatric endoscopic surgery at the University of Pretoria, and that was presented by Dr.
Tom Lowe.
From the United States.
Right.
In October 2002, you attended a course in advanced minimally invasive pediatric surgery at the Nelson Mandela Hospital, the Nelson Mandela School of Medicine at the University of Natal, and that was presented by Dr. P. Epicurem from Belgium.
Patrice Erpicum.
Erpicum, I beg your pardon, my lord, that's spelled E-R-P-I-C-U-M.
A great friend.
Yes. And that course included a specific module on misunderplication.
Correct.
Yes. Have you worked with Dr. Erpicum?
Dr. Erpicum actually trained with us in Johannesburg. He spent 7 years here, and then he returned to Europe and became highly successful and a pioneer in endoscopic surgery. He was a multi-talented individual, and he and I remain friends forever. And I visited him in Belgium, and I had the opportunity of assisting him with laparoscopic applications in Namur and in Liège.
Let's spell those for the record. Namur is N-A-M-U-R-E, Liège, L-I-E-G-E.
Correct.
Those are towns in Belgium.
Yes.
Next course is in September 2010. You attended a course you attended an advanced endoscopic workshop course in the University of Cape Town, and that's presented by Dr. Keith
Georgeson from Texas, Austin, Texas.
What is the endoscopic, laparoscopic procedure which you have performed most frequently in your career as a surgeon?
And by far the most frequent is Nissen van der application.
And it's difficult to give precise numbers, but can you give His Lordship an estimate of how many Nissen fundoplication operations you had performed before you operated on Zay and Syed? And could you distinguish between laparoscopic Nissen fundoplications and open Nissen fundoplications?
Well, I have on record all the laparoscopic Nissen fundoplications that I did. And in fact, there are 360 cases on record. I don't have the record of the open procedures done before that time, but it would have been at least 100. It's a conservative estimate.
So that's, just to check, 360 confirmed Nissen laparoscopic Nissen fundoplications, those you have the records.
Yes.
You estimate 100 open Nissen fundoplications, but
Yes.
you don't have records for those.
And you know, my experience of 360 is fairly modest compared to some series in the world, but it's not a minimal experience.
Professor Beale, can we then just move into the mechanics, as it were, of a Nissen fundoplication operation? And His Lordship has heard evidence already. You've been in court. But can you just explain to His Lordship what the Nissen fundoplication operation is there to deal with and how it is performed in general loose terms? And if I could ask you to start with the pipe, as it were, that connects the mouth and the stomach.
Yeah, which is called the esophagus. And this operation is done for reflux. And most children who have the operation do not have an associated hiatus hernia, whereas most adults do have an hiatus hernia, where you've got to correct the hiatus hernia. And it's become less popular in adults, but the indications in children have not changed, because in children there's an incompetent distal esophageal sphincter.
Can I just stop there? Incompetent distal esophageal sphincter. In lawyer language, that is the sphincter between the pipe that I've referred to, the esophagus, and the stomach.
Yes, sir. And so there are a range of indications in children to do this, but mainly for reflux esophagitis. And what you do is you've got to mobilize the...
Professor Beale, can I just interrupt you again? Will you explain to His Lordship how, if there is a competent lower esophageal or distal esophageal sphincter, what does that do in a normal human being?
Well, it prevents excessive reflux, which is the return, flow back of gastric content, gastric juices, which are predominantly acidic, up into the esophagus, and for a variable extent. To cause esophagitis and inflammation of the lower extent of the esophagus. Sometimes it can be all the way up to where the esophagus becomes the pharynx, in which case children may aspirate that fluid into their lungs and present, for instance, as an asthmatic child, and you've got to differentiate whether they've actually got asthma or whether they've got repeated aspiration.
What are the mechanics, as it were, of that esophageal sphincter that stops the reflux out of the stomach?
Well, it's an intrinsic sort of in the muscle.
His Lordship about pressures.
Yeah, that creates increased pressure in that lower extent of the esophagus to prevent reflux.
Mr. Green, I'm going to give you just one more question before we take a break.
And Professor Beale, just on pressures, it's simple fluid dynamics. If you've got to move a volume through a narrower area or a lower caliber, it goes through at a high pressure. Is that
Yeah, that's well stated. Thank you.
well, thank you.
Let's take our adjournment at this point, which shall proceed to Chief Pre-operative.
All rise.
By you re-establish the phenoesophageal ligament, and you put in what's called box arterial sutures, which include the top of the fundoplication and the phenoesophageal ligament.
Professor Beale, if I can interpret into lawyer language, and please tell me if I have it wrong. You take the top of the stomach and you wrap it around the esophagus and stitch it so that it's formed a ring around the esophagus. Is that
Forms a ring, and in fact a high pressure zone, which is very effective.
So my next question is, that ring of stomach around the esophagus, in the fluid dynamic language that we've spoken about, what does it do?
It prevents return of gastric content fluid up into the esophagus and corrects the reflux that has been present.
And Professor Beale, the procedure that you've described, when performed in children, does it happen above the diaphragm or below the diaphragm?
Below the diaphragm. So
You've previously mentioned that in laparoscopic surgery, ports are used. In a little more detail, could you tell His Lordship, let's start with, how many ports are there when a Nissen fundoplication is carried out laparoscopically?
there are 3 ports, my lord, but one does introduce an additional instrument through the abdominal wall, below the right costal margin, the margin of the ribs on the right side, and this is for a retractor. And the one we use is called a Nathanson retractor.
Could you just briefly describe the position of the incisions and the ports that are created for a Nissen fundoplication?
Well, you get the umbilical port where the lens is passed, and then you get 2 working ports laterally on both sides, just lateral to the rectus abdominis on each side at a suitable level, and then the Nathanson retractor through the incision below the right costal margin, and this you manipulate so that it's got a kind of a loop which fits under the left lobe of the liver and lifts it up. And this plus the insufflation of the peritoneal cavity and the positioning of the patient. And positioning, we usually ask for head up, so that the other intra-abdominal organs fall back and downwards. It's called an anti-Trendelenburg position, but that's a medical term. So the patient is in head up, and then that gives you maximal access.
And the Nathanson retractor that you have referred to and pulling back of the liver with that device, is that because the liver is in the way of where you need to operate?
Yes, it tends to be in the way.
Could we then turn to more specifically your treatment of Zayan. When you first saw Zayan, can you recall where it was that you first saw him?
I saw him in my sessional rooms at Park Lane Clinic, in the consulting room on the left, and he was with his mother and somebody else who was introduced as the mother's sister, and they had been referred by Dr. Riaz Khan.
Before we get there, did you have an administrative assistant in your rooms?
Yes,
Mrs.
Avril Jimmy.
On what days did you operate at the Park Lane Clinic?
On Tuesdays and Fridays in the afternoon.
And did you have, can I call it a general booking, or did you have to make specific bookings for Tuesday and Fridays?
No, I had general booking of the theatres for those particular times.
And who performed the anaesthetic work for you on the Tuesdays and the Fridays?
The Tuesday anaesthetist was a Dr. Ernie Welsh, an outstanding.
Just pick up your voice and spell out the name, last name at least for me.
Dr. Ernie Welsh, E-R-N-I-E, Welsh, W-E-E-L-C-H, was my Tuesday afternoon anaesthetist, top-rated anaesthetist in Johannesburg. And on Friday afternoon, lately it was Dr. Abdul Munshi, who unfortunately became deceased on the 16th of September 2020.
Yes, and who, you said latterly Dr. Munshi, who was it before Dr. Munshi?
Dr. Linda Blasowski.
Yes. Now, you've said that you first saw Zayan in your rooms at the Park Lane Clinic. Had you been told about Zayan before you saw him?
Yes, Dr. Riaz Khan had discussed him with me informally, either on the ward or in the corridor, and told me that he had this patient who had reflux, and he wanted to refer them, and I said they could certainly come and see me. And I explained to him at the time that there was a surgical option to correct reflux called the Nissen fundoplication, which he wasn't aware of or didn't understand, didn't have the concept of the operation until I explained it to him.
The first consultation, there's no debate about it, with Zayan was on the 29th of August. You said a moment ago that Zayan's mother was with him and there was somebody else. Who was she introduced to you as?
As the mother's sister.
Could I ask Professor Beale if you could take out exhibit ZZM? I'll ask somebody to help you with that. Mr. Boycer will help you. The files are not in front of you. The Lord, it's on case lines at page 5-63. It seems the witnesses' files have not been updated. We're not sure why that is so.
Lord, I've got an extra copy.
I'm indebted to my learned friend.
Just repeat for my benefit the references.
Lord ZZM, so Zulu Zulu Mike.
Or
And
Mike,
it's-
not N.
No, Mike, I beg your lordship's pardon. And it's-
5-650.
As your lordship pleases. Yes. Professor Beale, could you turn to the page? I know yours has the numbers on the top. It
Yes.
doesn't. It's the third page of the document, and the one that is a printed document, and it says "Verskillende besonderheden" in the top left-hand corner. Do you have that?
Sorry, sir, it says what?
I'm going to ask Mr. Boyce to help you.
It says personal details of the patient.
Yes, I could have that.
So I'm going to ask Mr. Boyce just to help you, because yours isn't numbered, Professor Beale, with the case lines numbered. So, my lord, I'm at page 5-63. Yes. Professor Beale, that page that is in front of you, can you tell his lordship what it is? Sorry, Professor Beale, if you'll just look at me and just pay attention. It's very important that you do not page on. I need you to have in front of you a very specific page. And Mr. Boyce is going to place that page in front of you. You have that. You have 5-65 in front of you. What is that document that is being shown on the page?
Personal details of the patient.
It says at the foot, tidy files. Does that help? Look at the foot of the page in the left-hand corner.
Yes, tiny file.
What is this? Is this a document? Is this a file? Is this a book? What is it?
It's a document with the patient's details, except this one here is incompletely filled in.
If you turn to the next page, 5-66,
Yes.
that is headed with your name, and it says patient registration and account application. Could you tell his lordship how that document would typically be prepared when a patient comes to see you?
Now, this document is filled in the reception, is given to the patient by the receptionist,
That's Mrs. Jimmy you prefer to.
Mrs. Jimmy, and they are requested to fill it in, and I see in this case it's been done by the patient's mother.
Could you then turn to the sixth page of the document you have? It's 5-68, my lord. Without going into the detail, just tell his lordship what that document is that is on that page.
See, it's notes that I made the first occasion that I saw young Zayan.
Yes, yes. My lord, for your lordship's reference, these documents also, or this document, the notes of Professor Beale, also appear at Exhibit ZT, Zulu Tango, and that's at 3-1015. Professor Beale, when you first met Ms. Baele and Zayan, did you introduce yourself to them?
I did.
And how did you introduce yourself? Did you have a normal way of introducing yourself?
Yes, the same as the court introduces me every day. Peter Beale.
No professor, no doctor. Were you just Peter Beale?
Yes.
All right. Can you use your notes that we've looked at, which are at page 5-68, if you will, and can you tell his lordship what you were told about Zayan?
Well, I was told, firstly, he was 10 years old and he suffered from reflux and vomiting. That he'd been seen by a bunch of other doctors, and I haven't named them here. That one was the pediatric gastroenterologist, Dr. Wallach, and she prescribed, apart from PPIs for reflux, enemas for what sounds like radiological diagnosis of fecal loading, because I'd established that he was stooling regularly anyway, and I thought that was excessive to be giving this poor youngster daily enemas. The next information was that he had been vomiting for over a month, white foam. He previously vomited twice a day, but now it escalated and become worse. That since he'd been seen by Drs. Khan and Wallach, he was on a proton pump inhibitor to decrease the acidity of the gastric secretions, and he was receiving Nexium 40 milligrams a day. And this is an adult dose actually, but he was a large 10-year-old, so probably appropriate. And I put there no benefit in terms of his symptoms. So it had no relief of symptoms, retrosternal pain, which one interprets as heartburn, and this has started at about 4 years of age. There'd be no recollection of abnormal vomiting as a baby. The other thing I noted here was that he'd had a barium swallow done before, and this had been ordered for him by Dr. Martin Davis, a pediatrician at Linksfield Clinic, when he was 4 years old, and nothing abnormal had been detected on that barium swallow. But barium swallow is not a priority investigation for reflux. He'd seen other pediatricians. He'd been admitted by Dr. Esat Musa to Garden City Clinic. Dr. Kassel, Jack Kassel, who was a witness, had seen him over a number of years, but in fact never considered that he might be refluxing. Dr. Kassel had done a CT scan, in which he saw enlarged nodes in the mesentery, which surgeon would refer to as mesenteric adenitis, which is just a response to a systemic viral infection usually. And then I've stated that he's for an endoscopy and biopsies.
Once you had been told of Zayan's complaints by his mother, what did you then do?
Well, his complaint was fairly severe. I examined him, got him to lie down and palpated his abdomen. And the only sort of positive finding was that he was tender in his epigastrium.
Where is the epigastrium?
It's just below the costal margin once again, and the Ziphy sternum, which is the bottom of the sternum.
Body language in the middle, just below the ribs.
Exactly.
Once you had examined Zayan, did you have a discussion with Mrs. Baele?
I did, and I suggested that Zayan needed a scope and biopsy. We discussed whether he should have the barium swallow again. Zayan was quite a reactive little boy, and I didn't think he would cooperate well with the swallow. And secondly, I wasn't sure that it would have any value, not being a recommended investigation for reflux by the Gastroenterological Society of North America. And I explained that The definitive diagnosis in his case would be acquired by doing an endoscopy, gastroscopy, and doing biopsies of the distal esophagus, the bottom end of the esophagus.
So I'm just going to tell Mr. Boyce that the next document you need to look at is some questions down the road so he can rest his legs for now.
Good, thanks.
Yes. Do you recall if at that first consultation, after having examined Zayan and when chatting to Mrs. Baele, do you recall if you mentioned a Nissen fund application as a possible surgical procedure?
I'm not absolutely sure, but I think I probably did. But at that time it was not really on the cards until we'd done an endoscopy and either excluded or confirmed the diagnosis.
Now, we know that the biopsy is carried out and performed on the 3rd of September 2019. Can you just describe generally to His Lordship how a biopsy is carried out? And then separately, we'll come to what you saw during the biopsy on Zayan. So can we start with the first one? Generally, how do you carry out a biopsy?
Well, the biopsy, first you observe, of course, but we'll come to that. But the biopsy is taken through the endoscope. There's a separate channel.
I understand this is all first hand. Do you anesthetize the patient? And is it done in hospital?
It's done on a hospital admission under general anesthetic in a child.
Pick it up from that point.
So with the patient anesthetized, one introduces a flexible fiber optic instrument, which is an endoscope, through which has a fiber optic channel, which you can very clearly see the internal features of the esophagus, the stomach, and go through into the duodenum and complete an upper gastrointestinal endoscopy. Biopsies are done through a biopsy channel in the endoscope with an instrument that has little cup-like biopsy instrument that opens and closes and cuts and removes a little biopsy specimen, a bit larger than a pinhead, so 2 or 3 pinhead size, and one takes several. I think in Zayan's case we took 4, and these are submitted to the pathologist in formalin, which fixes the tissue, and is then examined by the pathologist, having stained and sectioned the biopsy specimens, and then reported on as to what their findings are.
And just that, I think it's probably clear to everybody in the court, when you say you introduce the gastroscope, it's introduced into the body through the patient's mouth. Is that correct?
Through the mouth and down the esophagus, the pipe between the pharynx and the stomach.
Professor Beale, will you now tell His Lordship what you saw when you were performing the biopsy on Zayan?
Oh, well, when one got to the lower end of the esophagus, extending for several centimeters, probably 4 or so centimeters, from the gastroesophageal junction, there was an area of inflammatory change with obvious red inflamed esophagus, and there was a wavy pattern of the proximal end of that, which I described as tongue-like extensions, and this was very convincingly confirmatory of reflux esophagitis. and the said biopsies were taken in that area.
Mr. Sire gave evidence that he was present at the hospital on the day of the gastroscopy. Do you recall with him being there? Or?
He may have been there, I don't really recall.
After the biopsy, do you recall chatting to Ms. Baele about what you had seen?
Yes, I do.
And could you just tell His Lordship what you told her after the biopsy?
I told her that my finding was that Zion did have reflux esophagitis, but we needed to wait for what I previously referred to as objective confirmation or evidence in the form of a biopsy report that there was in fact esophagitis present at the lower end of the esophagus.
His Lordship knows that the biopsy results became available on the 10th of September 2019. Generally, would you tell His Lordship what your procedure is when you receive biopsy results from a laboratory? And then we'll move on to Zion later. So generally, what is your procedure?
When you observe what the report is from the pathologist, and we either contact the parent and advise them and notify them of the outcome is, or sometimes parents are phoning you before you have a chance to notify them, to request the outcome.
Ms. Baele has given evidence to His Lordship that she spoke to you about the biopsy results on the telephone. Do you agree that you spoke with her on the telephone?
Yes, I did. She was in Cape Town.
Tell His Lordship what you can recall telling Ms. Baele during that telephone call.
What I told her was, firstly, and the reason why I looked at the biopsy at that time was to confirm that there was chronic esophagitis, or what the pathologist refers to as chronic mild esophagitis, which means there's no erosion or ulceration at that time and no stricture. So I told her, confirmed that Zion had chronic reflux esophagitis, but I also had, in looking for that confirmation of reflux esophagitis, I had mistakenly seen that there was also reference to intestinal metaplasia, and I would apologize that and I looked at it and I registered it, and I believe that was the case, and would have been not inconsistent with what I saw. And it's not a pre-malignant condition, it's really a change of the mucosal pattern in areas of reflux.
If you could just stick to what you told
then
Mrs.
that's what I
Baele
told
during
Miss Baele, she was called. And I suggested to her that this confirmed the indication for anti-reflux procedure.
I'm not so sure what you told. I'm going to ask you to repeat it for my benefit.
So
Professor Beale, let me help you, because I think and if I could ask you to focus on the question, it is when you spoke to Ms. Baele when you had the laboratory results, what did you tell her?
I told her that there was a confirmation of reflux esophagitis, but I also told her they reported intestinal metaplasia. Now, I'd picked that up,
Professor
but
Beale,
it turned
hold
out
on.
to be...
I'm sorry, I'm going to interrupt you.
Yes.
Stick to what you... His Lordship wants to know what you told Ms. Baele.
Yes, that's
so
what
you
I
told
told
her there's esophagitis, you told her there's intestinal metaplasia. Did you tell her anything else?
No.
Did you explain
I think-
intestinal metaplasia to her?
I did at some stage, I'm not sure whether it was on the telephone at that stage.
Now, we all know that the
Just
report...
one moment, please. I'm going to ask you, Mr. Green, to repeat the last question you posed to him. And this time I was still making note.
Yes, I beg your Lordship's
Yes.
pardon. Did you explain to Ms. Baele what intestinal metaplasia is?
She asked me, and I did explain to her at some stage, and I'm not sure it was at that initial phone call or not, or whether it was subsequent.
Well, if it was at that telephone call, can you tell His Lordship what it was that you offered to Ms. Baele as an explanation of intestinal metaplasia?
It's the result of long-term reflux where you get a change in the mucosa, where there's due to inflammatory change, you get an intestinal mucosa substituting normal esophageal mucosa with an intestinal pattern, which is metaplasia, is a change from one type of tissue to another.
And what did you explain what the consequences of that may be?
I was asked, and I said, I don't know whether it was then that if the reflux was untreated, then that would persist and develop and may, in time, develop a condition called Barrett's esophagitis. It's very uncommon in youngsters, and I think I've only seen it once in a teenager. And Barrett's esophagitis had a potential for, like a 20% potential for malignant change in later life. So it's an indication, additional indication to correct the reflux.
Now, Professor Beale, we all know that the report says there is no intestinal metaplasia.
Yes.
Did you intentionally misread the report so that you informed Mrs. Syed that there was intestinal metaplasia?
No, it was not intentional at all.
Can you
I misled her and I misled myself.
Can you, of course one has got to reconstruct these things, are you able to, with the reconstruction, offer His Lordship any explanation for why you misread the report?
Just before you do, he does. My concern, Mr. Green, is that at times you are asking a person whereas and in fact he says something. In other words, you are asking a person when he's trying to respond. My worry is that later on I would want to go back to the report and not pick up what he said. Because I cannot pick up word for word what he's saying at this point. And I ask you as I did right at the beginning of the time, be patient with witnesses, be patient with yourself. I'm aware that you are eager that you must get this over done with. I'm aware that it's a time problem, but I'm very keen to hear what he has to say, following from your question.
I'll bear that
Is that a fair question?
It is, my Lord, I'll bear that in mind.
Please do.
And my Lord, if I may just repeat it for Professor Beale, because I think we both probably doing that a little bit. We speaking over each other.
It should not happen.
Lord, I'll make a special effort to try and avoid that. Professor Beale, you misread the report. With the benefit of reconstruction, are you able to offer to his lordship an explanation for why you think you may have misread the report?
Well, I was looking at the report specifically at that time to confirm whether there was esophagitis or not, which is what I was looking for.
Yeah, just hold on. It's not noting the question. Hold it. Just repeat yourself, sir. We're looking at the report, yes?
To confirm finding of esophagitis, which would be an indication to do anti-reflux surgery on this patient. And my intention was specifically to confirm esophagitis and notify Miss Baele. But in doing so, I picked up the pathologist's report on intestinal metaplasia and other things. And the pathologist, unfortunately, also doesn't just give you the positive findings, gives you the negative findings. Like there's no intestinal metaplasia. And I misread that at the time to say there was intestinal metaplasia, which would just be a sort of an additional reason to correct reflux in Zayon. And was never a primary indication.
Professor Beale, we know that from the evidence that's been given that a misinfunded application operation was then recommended by you.
Yes, yes, my lord.
Could I ask you to tell his lordship what your advice would have been based on your clinical judgment if you had correctly read the laboratory report and if you had seen that there was no intestinal metaplasia? What would your advice have been?
My advice wouldn't have changed at all.
And tell his lordship why your advice would not have changed.
With the investigation and was to confirm gastroesophageal reflux, and that was what the intention was. Poor Zayon's life was miserable, vomiting all the time, in pain, and had not responded to medical treatment, which was a clear indication that he needed that procedure. And the intestinal metaplasia slip was by the way, but the anti-reflux procedure would have reversed that process and prevented any further progression of it. It was not an urgent thing. There was no suggestion that there was malignancy or that Zayon was going to die, which is what we subsequently heard.
Yes. Professor Beale, did your observations during the gastroscopy play any role in the treatment which you recommended?
But it didn't cause me to exclude it completely, because the sort of appearance of the distal esophageal mucosa did not exclude the possibility of intestinal metaplasia, of a change in the mucosa.
Now, you mentioned a moment ago when you spoke to Mrs. Syed, that was her evidence, she was in Cape Town. Was there a discussion with Mrs. Syed about whether she and Zayan needed to return home for further treatment urgently?
There was a discussion, and they asked if they needed to come back urgently, and I said no, there was no urgency about it. But it had to be done sometime, and I would suggest they didn't neglect it long term.
Just raise your voice, it's starting to trail off again, Professor.
Sorry.
Yes. Just repeat that last answer.
I said they needn't interrupt their holiday and come back. That he didn't need an urgent surgery, but I didn't think they should delay it or avoid it long term.
Mr. Syed gave evidence that he telephoned you on the 10th of September. Do you recall if that conversation, I beg your pardon, the 11th of September? Apologies, the 11th of September. Do you recall that?
I think that's probably true, but I don't have a good recollection of that.
Professor Beale, it seems that the next contact you may have had with Mrs. Syed is then on the 6th of October when a text message is sent to you. I'm going to ask Mr. Boycer to help getting the text message before you. Lord, it's in Exhibit ZH, Zulu Hotel, and it's at page 3-943.
I have it, thank you.
Mine is just loading, Professor Beale, on the case line system. Now, you have the text message that you see at the top there. You confirm you received that text message?
I do.
Yes. And your response is sure. And do you recall if Mrs. Syed and Zayan came to see you after this text message?
They did.
Do you recall, was that the same day or the next day? Or later?
The same day.
Where did that consultation take place?
In the same consultation room that I saw them the first time.
And can you then tell His Lordship what Mrs. Syed had told you, and perhaps we can get before you your notes, which we have looked at previously. Do you have those handy?
Yes, I do.
Yes. Would you tell His Lordship what happened at that consultation?
Miss Baele told me that Zayan had improved initially when they were in Cape Town. He was on his Nexium 40 milligrams a day. That had recurrence of symptoms since returning to Johannesburg. That he'd not returned to school at all. And I was shown videos of retching that they referred to as spewing into a toilet. And we discussed laparoscopicness and procedure.
Can you tell His Lordship what you discussed with Ms. Baele about laparoscopicness and procedure?
I told her that it was an operation that is done laparoscopically. It's minimally invasive. It diminishes the discomfort that youngsters who have innocent fundoplication done laparoscopically generally go home by the end of the next day, but they might spend an extra night in hospital. I described to her more or less how the operation is done, and it was my usual practice to draw the procedure on a consultation form, prescription form, and show them how it is done. And
Did you deal with post-operative diet?
Yes, we did. And I told them that for a week or so there were certain elements in the diet that we suggested that they avoid, and particularly fibrous stuff like biltong, white chicken, and otherwise reasonably soft diet in the first week after the operation. I warned them that occasionally patients might struggle to swallow a little bit. Very occasionally they might need a dilatation. Maybe in 1% of cases before they settle down. And very, very, very seldom they might need revision of the fundoplication if there was a recurrence of reflux in time, or if there was total dysphagia. Now, the only case I ever had to go back on was one that Tom Loeb did for us in Johannesburg. But to his great embarrassment, I had to take it down and redo it.
Did you deal at all with post-operative pain management?
Yes, I told them that the benefit of a laparoscopic procedure was that post-operative pain was less. Firstly, one would give a local anesthetic intraperitoneal, and secondly into the port site areas, and this would help for the post-operative pain. And apart from that, they would get the usual pain medication, which at that time was, still is, I think, is intravenous paracetamol, which is Prevalvin.
Now, Professor Beale, can you recall when Zayan was first scheduled to undergo the Nissen fundoplication operation?
He was scheduled to have a fundoplication on a Tuesday afternoon of the week of
the 6th and 7th.
6th and 7th. Yeah.
And that Tuesday, we checked the calendar, that's the 8th of October.
Yes.
Professor Beale, can I ask you, you seem to be tiring, do you need a break?
No, I'm fine, thanks.
Right. Can you tell His Lordship what you can recall happened on the morning of Tuesday, the 8th of October? Let's start with the hospital and then move on.
Yes, Zayan was the only patient booked for that particular Tuesday afternoon, and Dr. Welsh would have given him an anaesthetic. At the last moment I was informed by the nursing staff that the Sayed family had cancelled the surgery, and in fact Dr. Welsh had already arrived at the hospital when we were informed that it had been cancelled. And so, he moved on and went and attended to other emergency anesthesias elsewhere, so it wasn't available again. And about mid-afternoon, I think Mrs. Baele phoned me to say they now wanted to have the operation done, and I had to tell her that it wasn't possible to do it still that afternoon because I didn't have a scheduled anaesthetist, and the anaesthetist had moved on and become involved in other procedures.
Professor Beale, did you receive a telephone call from Dr. Kussel on the 8th of October?
Yeah, I did.
Yes. And just to get the order right, are you able to tell His Lordship whether the call from Dr. Kussel was before the telephone call you've just referred to from Mrs. Baele, or after that telephone?
I think before.
And can you then tell His Lordship what you can recall of the discussion with Dr. Kussel?
Dr. Kassel was dubious about whether this operation should be done for Zayon, but as an elderly pediatrician, Dr. Kassel had no concept of an anti-reflux operation like this. And I told him that the biopsy had confirmed chronic esophagitis, and I also said there was, because I was also still under the impression that there was intestinal neoplasia, and I told him there was this combination of findings, and told him that I really thought that it was, the procedure was well indicated, which it was, which I still think. And he then told me he would advise them to go ahead with the procedure for this. And there was a wavy pattern of the proximal end of that, which I described as tongue-like extensions. And this was very convincingly confirmatory of reflux esophagitis. And the said biopsies were taken in that area.
Mr. Sire gave evidence that he was present at the hospital on the day of the gastroscopy. Do you recall with him being there? Or?
You may have been there, I don't really recall.
After the biopsy, do you recall chatting to Ms. Baele about what you had seen?
Yes, I do.
And could you just tell His Lordship what you told her after the biopsy?
I told her that my finding was that Zayon did have reflux esophagitis, but we needed to wait for what I previously referred to as objective confirmation or evidence in the form of a biopsy report that there was in fact esophagitis present at the lower end of the esophagus.
His Lordship knows that the biopsy results became available on the 10th of September 2019. Generally, would you tell His Lordship what your procedure is when you receive biopsy results from a laboratory? And then we'll move on to Zayon later. So generally, what is your procedure?
When you observe what the report is from the pathologist, and you either contact the parent and advise them and notify them of the outcome is, or sometimes parents are phoning you before you have a chance to notify them, to request the outcome.
Ms. Baele has given evidence to His Lordship that she spoke to you about the biopsy results on the telephone. Do you agree that you spoke with her on the telephone?
Yes, I did. She was in Cape Town.
Tell His Lordship what you can recall telling Ms. Baele during that telephone call.
What I told her was, firstly, and the reason why I looked at the biopsy at that time was to confirm that there was chronic esophagitis, or what the pathologist refers to as chronic mild esophagitis, which means there's no erosion or ulceration at that time and no stricture. So I told her, confirmed that Zayon had chronic reflux esophagitis, but I also had in looking for that confirmation of reflux esophagitis, I had mistakenly seen that there was also reference to intestinal metaplasia, and I would apologize that and I looked at it and I registered it, and I believe that was the case, and would have been not inconsistent with what I saw. It's not a pre-malignant condition, it's merely a change of the mucosal pattern in areas
Professor Beale,
of
I'm going to stop
reflux.
you. If you could just stick to what you told
And
Mrs.
that's what I
Baele
told
during it.
Miss Baele, she was called. And I suggested to her that this confirmed the indication for anti-reflux procedure.
I'm not so sure what you told. I'm going to ask you to repeat it for my benefit.
Yeah, so
Professor Beale, let me help you, because I think, and if I could ask you to focus on the question, it is when you spoke to Ms. Baele when you had the laboratory results, what did you tell her?
I told her that there was a confirmation of reflux esophagitis, but I also told her they reported intestinal metaplasia. Now, I'd picked that up,
Professor
but
Beale,
it turned
hold
out
on.
to be,
I'm sorry, I'm going to interrupt you.
yes,
Stick to what His Lordship wants to know what you told Ms. Baele.
Yes, that's
so
what
you
I
told
told
her there's esophagitis, you told her there's intestinal metaplasia. Did you tell her anything else?
no.
Did you explain
I think-
intestinal metaplasia to her?
I did at some stage, and I'm not sure whether it was on the telephone at that stage.
Now, we all know that the
Just
report...
one moment, Mr. I'm going to ask you, Mr. Green, to repeat the last question you posed to him. And this time I was still making notes.
Yes, I beg your Lordship's
Yes.
pardon. Did you explain to Ms. Baele what intestinal metaplasia is?
She asked me, and I did explain to her at some stage, and I'm not sure it was at that initial phone call or not, or whether it was subsequently.
Well, if it was at that telephone call, can you tell His Lordship what it was that you offered to Ms. Baele as an explanation of intestinal metaplasia?
It's the result of long-term reflux where you get a change in the mucosa, where there's due to inflammatory change, you get an intestinal mucosa substituting normal esophageal mucosa with an intestinal pattern, which is a metaplasia, is a change from one type of tissue to another.
And what did you explain what the consequences of that may be?
I was asked, and I said, I don't know whether it was then that if the reflux was untreated, then that would persist and develop and may, in time, develop a condition called Barrett's esophagitis. It's very uncommon in youngsters, and I think I've only seen it once in a teenager. And Barrett's esophagitis had a potential for, like a 20% potential for malignant change in later life. So it's an indication, additional indication to correct the reflux.
Now, Professor Beale, we all know that the report says there is no intestinal metaplasia.
Yes.
Did you intentionally misread the report so that you informed Mrs. Syed that there was intestinal metaplasia?
No, it was not intentional at all.
Can you
I misled her and I misled myself.
Can you, of course one has got to reconstruct these things, are you able to, with the reconstruction, offer His Lordship any explanation for why you misread the report?
Just before you do the task, my concern, Mr. Beale, is that at times you are asking a person whereas I'm in fact saying something. In other words, you are asking a person when he's trying to respond. My worry is that later on I would want to go back to the report and not pick up what he said. Because I cannot pick up word for word what he's saying at this point. And I ask you as I did right at the beginning of the time, be patient with witnesses, be patient with the staff. I'm aware that you are eager, that you must get this over done with. I'm aware that there's a time problem, but I'm very keen to hear what he has to say. Following from my question.
I'll bear that.
Is that a fair question?
It is, my Lord, I'll bear that in mind.
Please do.
And my Lord, if I may just repeat it for Professor Beale, because I think we both probably doing that a little bit. We are speaking over each other.
It should not happen.
Lord, I'll make a special effort to try and avoid that. Professor Beale, you misread the report. With the benefit of reconstruction, are you able to offer to His Lordship an explanation for why you think you may have misread the report?
Well, I was looking at the report specifically at that time to confirm whether there was esophagitis or not, which is what I was looking for.
Yeah, just hold on. It's only not in the question. Audit. Just repeat yourself, sir. You're looking at the report, yes?
To confirm finding of esophagitis, which would be an indication to do anti-reflux surgery on this patient. And my intention was specifically to confirm esophagitis and notify Miss Baele. But in doing so, I picked up the pathologist's report on intestinal metaplasia and other things. And the pathologist, unfortunately, also doesn't just give you the positive findings, gives you the negative findings. Like there's no intestinal metaplasia. And I misread that at the time to say there was intestinal metaplasia, which would just be a sort of an additional reason to correct reflux in the Zayon. And was never a primary indication.
Professor Beale, we know that from the evidence that's been given that a misinfunded application operation was then recommended by you.
Yes, my lord.
Could I ask you to tell His Lordship what your advice would have been based on your clinical judgment if you had correctly read the laboratory report and if you had seen that there was no intestinal metaplasia? What would your advice have been?
My advice wouldn't have changed at all.
And tell His Lordship why your advice would not have changed.
With the investigation and was to confirm gastroesophageal reflux, and that was what the intention was. Poor little Zion's life was miserable, vomiting all the time, in pain and had not responded to medical treatment, which was a clear indication that he needed that procedure. And the intestinal metaplasia slip was by the way, but the anti-reflux procedure would have reversed that process and prevented any further progression of it. It was not an urgent thing. There was no suggestion that there was malignancy or that Zayan was going to die, which is what we subsequently heard.
Yes. Professor Beale, did your observations during the gastroscopy play any role in the treatment which you recommended?
But it didn't cause me to exclude it completely, because the sort of appearance of the distal esophageal mucosa did not exclude the possibility of intestinal metaplasia, of a change in the mucosa.
Now, you mentioned a moment ago when you spoke to Mrs. Syed, that was her evidence, she was in Cape Town. Was there a discussion with Mrs. Syed about whether she and Zayan needed to return home for further treatment urgently?
There was a discussion, and they asked if they needed to come back urgently, and I said no, there was no urgency about it. But it had to be done sometime, and that I would suggest they didn't neglect it long term.
Just raise your voice, it's starting to trail off again, Professor.
Sorry.
Yes. Just repeat that last answer.
I said they needn't interrupt their holiday and come back. That he didn't need an urgent surgery, but I didn't think they should delay it or avoid it long term.
Mr. Syed gave evidence that he telephoned you on the 10th of September. Do you recall if that conversation, I beg your pardon, the 11th of September? Apologies, the 11th of September. Do you recall that?
I think that's probably true, but I don't have a good recollection of that.
Professor Beale, it seems that the next contact you may have had with Mrs. Syed is then on the 6th of October, when a text message is sent to you. I'm going to ask Mr. Boycer to help getting the text message before you. Lord, it's an exhibit ZH, Zulu Hotel, and it's at page 3-943.
I have it, thank you.
It's just loading, Professor Beale, on the case line system. Now, you have the text message that you see at the top there. You confirm you received that text message?
I do.
Yes. And your response is sure. And do you recall if Mrs. Syed and Zayan came to see you after this text message?
They did.
Do you recall, was that the same day or the next day? Or later?
The same day.
Where did that consultation take place?
In the same consultation room that I saw them the first time.
And can you then tell His Lordship what Mrs. Syed had told you, and perhaps we can get before you your notes, which we had looked at previously. Do you have those handy?
Yes, I do.
Yes. Would you tell His Lordship what happened at that consultation?
Miss Baele told me that Zayan had improved initially when they were in Cape Town. He was on his Nexium 40 milligrams a day. that had recurrence of symptoms since returning to Johannesburg, that he'd not returned to school at all. And I was shown videos of retching, that they referred to as spewing into a toilet, and we discussed laparoscopic Nissen procedure.
Can you tell His Lordship what you discussed with Ms. Baele about laparoscopic Nissen procedure?
I told her that it was an operation that is done laparoscopically. It's minimally invasive, that it diminishes the discomfort that youngsters who have a Nissen fundoplication done laparoscopically generally go home by the end of the next day, but they might spend an extra night in hospital. I described to her more or less how the operation is done, and it was my usual practice to draw the procedure on a consultation form, prescription form, and show them how it is done. And
did you deal with post-operative diet?
yes, we did. And I told them that for a week or so there were certain elements in the diet that we suggested that they avoid, and particularly fibrous stuff like biltong, white chicken, and otherwise reasonably soft diet in the first week after the operation. I warned them that occasionally patients might struggle to swallow a little bit. Very occasionally they might need a dilatation. Maybe in 1% of cases before they settle down. And very, very, very seldom they might need revision of the Nissen fundoplication if there was a recurrence of reflux in time, or if there was total dysphagia. Now, the only case I ever had to go back on was one that Tom Loeb did for us in Johannesburg. But to his great embarrassment, I had to take it down and redo it.
Did you deal at all with post-operative pain management?
Yes, I told them that the benefit of a laparoscopic procedure was that post-operative pain was less. Firstly, one would give a local anesthetic intraperitoneal, and secondly into the port site areas, and this would help for the post-operative pain. And apart from that, they would get the usual pain medication, which at that time was, still is, I think, is intravenous paracetamol, which is Prevalgan.
Now, Professor Beale, can you recall when Zayan was first scheduled to undergo the Nissen fundoplication operation?
He was scheduled to have the fundoplication on a Tuesday afternoon of the week of
the 6th and 7th.
6th and 7th. Yeah.
That Tuesday, we checked the calendar, that's the 8th of October.
Yes.
Professor Beale, can I ask you, you seem to be tiring, do you need a break?
No, I'm fine, thanks.
Right. Can you tell His Lordship what you can recall happened on the morning of Tuesday, the 8th of October? Let's start with the hospital and then move on.
Yes, Aaron was the only patient booked for that particular Tuesday afternoon, and Dr. Welsh would have given him an anaesthetic. But at the last moment I was informed by the nursing staff that the Said family had cancelled the surgery, and in fact Dr. Welsh had already arrived at the hospital when we were informed that it had been cancelled, and so he moved on and went and attended to other emergency anaesthesias elsewhere, so wasn't available again. And about mid-afternoon, I think Mrs. Baele phoned me to say they now wanted to have the operation done, and I had to tell her that it wasn't possible to do it still that afternoon because I didn't have a scheduled anaesthetist, and the anaesthetist had moved on and become involved in other procedures.
Professor Beale, did you receive a telephone call from Dr. Cussell on the 8th of October?
Yeah, I did.
Yes. And just to get the order right, are you able to tell His Lordship whether the call from Dr. Cussell was before the telephone call you've just referred to from Mrs. Baele, or after that telephone?
I think before.
And can you then tell His Lordship what you can recall of the discussion with Dr. Cussell?
Dr. Cussell was dubious about whether this operation should be done for Zayon, but as an elderly pediatrician, Dr. Cussell had no concept of an anti-reflux operation like this, and I told him that the biopsy had confirmed chronic esophagitis, and I also said there was, because I was also still under the impression that there was intestinal neoplasia, and I told him there was this combination of findings, and told him that I really thought that the procedure was well indicated, which it was, which I still think. And he then told me he would advise them to go ahead with the procedure, which I suspect is when they phoned me and wanted it now to commence mid-afternoon, which was too late.
Now, Professor Beale, you've explained that it was then too late to reignite the procedure, as it were, on the 8th of October. The procedure is then, we know, is carried out on the 11th of October. Can you recall when it was agreed that the procedure would be carried out on the 11th of October?
Well, in the interim, Zayon was actually admitted because he...
Before we get there, yeah. Professor Beale, sorry, I asked my question very badly again. There is a booking made for the 11th of October.
Yes.
Do you know when that booking is made?
Well, the agreement was when they cancelled then, and they would inform that it couldn't happen that day. I told Mrs. Baele that the next opportunity would be in the next schedule, which was on a Friday afternoon, which was less ideal than the Tuesday.
All right, then. We know that Zayon came to see you on the 9th of October. Can you tell His Lordship what you can recall of that 9th of October visit?
They came in to see me again, and Zayon was just vomiting perpetually, not able to retain anything. And I didn't think he was dehydrated at the time, but I thought that it was very wise to admit him to hospital on an infusion while he was not able to retain anything, so he didn't become dehydrated. And I thought that he should probably stay in hospital overnight. pending his procedure on the Friday, because this was now the Wednesday. Now the Wednesday afternoon, and so I admitted him on an infusion, and next day, while he was in hospital, I considered that the only investigation he had not had to exclude any other possible diagnoses, alternative diagnoses, although I had very little doubt that his problem was gastroesophageal reflux and reflux esophagitis, and that he needed that to be resolved. But I scheduled a CT scan of the brain to make sure that the only thing that hadn't been investigated by any of the other doctors was the possibility of a space-occupying intracranial lesion raising intracranial pressure, which can be the cause of recurrent vomiting.
Mr. Beale, I'm sorry, but I need to take you back so that we don't lose the chronology of it. I need you to identify some documents for his lordship. Could I ask that Exhibit J, page 3-411, be placed before you? So 3-411 is the page number. Exhibit J. Professor Beale, that document, it's on your letterhead. Is that your admission?
That's correct, yes.
And we don't have a transcript of it. Would you just read what you have written there so that there's no doubt?
It's a request for the staff on the paediatric ward to admit 10-year-old Zayan to pediatrics for an intravenous infusion and intravenous medication. And then I state he's for a laparoscopic and come Friday.
It says thanks, and it's your signatures.
Yes.
You then referred his lordship to a CT scan which you ordered the following day, the 10th of October.
Correct.
Could you just explain to his lordship why you decided to order that CT scan?
I did give an explanation. It was a precautionary thing to order that, although that I was pretty convinced that Zayan had gastroesophageal reflux and that he was suffering from it for a number of years, that I wanted to rule out the other, however remote, possibility that he had a raised intracranial pressure, which you would get from an intracranial lesion in the brain, which is a possibility of a cause for recurrent vomiting. And the only thing that hadn't been investigated by any of the whole group of pediatricians that had seen Zayan over the years.
Professor Beale, in the file that is before you, in that same exhibit, Exhibit J, could you turn to page 3-435? If you can't find it, Mr. Boyce will come to help you.
3-45.
3-435. It's the report by ACR Radiology.
We'll find it too.
Mr. Boyce, I'll help you. Professor Beale, that document at page 3-435, would you just tell His Lordship what it is?
It's radiology report, reported on by Dr. Tracy Westcott Taylor, and it's a CT scan of the brain. It says indication known with gastroesophageal reflux disease, now persistent vomiting, query intracranial abnormality, and comment is no intracranial pathology identified.
Is this the report from the CT scan that you ordered on the 10th of
That's
October?
correct.
Yes. Can I ask you to tell His Lordship what would have happened if this report had come back and had identified intracranial pathology that could have been the reason for Zayan vomiting? Would you have carried on with the surgery, or would you have referred Zayan to somebody else?
Clearly I would not have carried on. I would have referred to somebody else, but I thought the expectation that there would be a problem was extremely low.
Then, Professor Beale, could I ask you in that same exhibit to turn to page 3-422, so it's a few pages earlier. It's the patient progress report.
Got it.
If you use the times as the reference point, and mine has a punch hole through the relevant time, it's 1500 hours, and the problem is doctor's rounds. You're able to locate it? It's
Yes,
about
I've got it.
And it says, patient seen by Professor Beale will sleep over for theatre procedure tomorrow. Do you recall seeing Zayan in the ward at about that time on the 10th of October?
Yes, I do.
And do you have a recollection of what happened after that? You'd seen Zayan, said he's going to sleep over. What then happened? Do you remember?
Well, then I got a call the late afternoon, early evening from the nursing staff saying that the side family wanted to take Zayan home for the night, and I said I had no objection and authorised it, approved that they could take him home, and potentially come back in the morning. I wasn't sure that they would, but they did.
And
then they didn't take him home straight away. So they were still around there until about 10 p.m. in the evening, where I got another call from the ward to say they were now going to take him home. And I just confirmed that it was authorised.
And just on that, there are a number of nursing notes. The last one looks as though it's 2200 hours. It says discharge.
It says Prof. Beale informed about
Can you read what is there?
the baby, I think.
Professor Beale, perhaps it's very difficult to read this, right?
It is.
Is this the later call you referred to, asking for Zayan to be discharged?
Yes.
And you confirmed, you said he could be discharged at 10 o'clock.
I did.
Then I'm going to ask Mr. Boyce to help you again. I need to take you to exhibit ZH. It's the text messages again.
Got in this file.
Mr. Boyce will help you. My Lord, that's at page 3-943 is the relevant one. Exhibit
number?
ZH.
Thank you.
Professor Beale, I'll just wait for everybody to get to Professor Beale. Professor Beale, there's the text message. There's one at the foot of the page of the 11th of October. It says, "Morning, Prof. Zayan has croup. He's coughing badly. Will he still have the op? Is it going to be on? Okay." And you responded, "Bring him prepared at 12. The anaesthetist will assess." Would you just explain to His Lordship why you said the anaesthetist will assess?
Because the anaesthetist is the one who decides whether the patient is fit and suitable for anesthesia. Miss Baele said Zayan had croup. Croup only occurs up to the age of 5. So it was unclear exactly what was going on. And I left it up to the anaesthetist, who was Dr. Abdul Munshi, and I briefed him before he went over to see Zayan as to what the situation was, and told him to make a careful assessment, which he did. And then he decided that there was a bit of pharyngitis. It was probably due to reflux.
I'm going to interrupt you there because I do need to get your evidence to His Lordship in a particular order. So I need to take you to some other documents first before we get to Zayan being admitted. You have a frog in your throat, as it were. There is water. Please do feel free to take a sip if you need.
Thank you.
Is that what you call it, a frog?
Frog in your throat, my Lord. Well, I don't know whether that's commonly accepted idiom, but certainly at home, if I say I have a frog in my throat, everybody knows.
Let me not use that expression.
Professor Beale, would
Yes.
you turn to the next page in the exhibit that is before you, to page 944. It's the continuation of the text message, where at the top you say, "Bring him prepared at 12. The anaesthetist will assess." The response is okay, and then there is another message from Ms. Baele to say, "Is it okay if he didn't eat at 8 and just had clear fluids until 10:30? And you responded yes. Is that correct?
Confirmed, yes.
Now, on the 11th of October, do you recall whether you arrived at the Park Lane Clinic before or after Zayan had been admitted to the hospital?
Afterwards, because myself and Dr. Munshi had anesthetized an operator on a patient just round the corner at the Branches Clinic.
Do you have a recollection of meeting Mr. and Mrs. Syed in the ward before the operation commenced?
I would expect so. I don't really have a recollection, but it would be very unusual for me not to go to the ward and meet with the patient prior to surgery.
Now, you started telling His Lordship a moment ago about the discussion that you had with Dr. Munshi about Ms. Baele's text and Zayan coughing.
Yes.
Just to get in the chronology of things, could you tell His Lordship about that discussion?
I briefed Dr. Munshi as to what Zayan's circumstances were, his indication for procedure he was going to have, and the fact that his mother had phoned me and said he had a croup-like symptoms, and suggested that he assess him, carefully and be very sure that he was fit for anesthesia and a procedure that afternoon.
And did Dr. Munshi report to you the results of his observations?
He reported that he was happy with Zayan, and he thought that a bit of upper respiratory symptomatology was related probably to acid reflux and persistent vomiting rather than anything else.
Was there mention made of blood tests by Dr. Munshi?
Dr. Munshi wanted to do blood tests. There were routine blood tests, but Zayan apparently declined, and his mother supported him, and so in fact the blood tests weren't done, they weren't essential.
Was Zayan your first surgical case of the day at Park Lane, or were there other cases ahead of him?
No, he was the first one at Park Lane Clinic.
Can you pick up events from when Zayan arrives at theatre? Can you tell his lordship who you spoke to and how Zayan was brought into theatre?
Zayan was in the theatre entrance with his father, Mr. Syed, and Zayan was protesting that he didn't want to have the procedure, and his father was encouraging him, and I spoke to Zayan and said everything's going to be okay, and that we're going to fix the problem that you've got. And that was obviously the absolute intention, and I was very keen to resolve Zayan's problem.
Did you speak to Mr. Syed and tell him what the expected duration of the procedure would be?
I told him the usual time for that surgery would be about an hour and a half. That proved to be an underestimate.
Now, just explain to his lordship the estimate of an hour and a half in the surgery. Does a surgeon work to a clock, as it were? That if you say an hour and a half, you get it done in an hour and a half, or is the approach different?
The approach is very different. You don't clock watch at all. You do the operation with meticulous attention to detail and not any attention to the passage of time. And my anaesthetist always used to say that I was over-optimistic and underestimated the times. And in series of operations, people talk about the mean operating time. And there are people who do this procedure in a mean operating time of, somebody in the United States might say 45 minutes to an hour. He's the world leading exponent of the operation. But there are many series where they say mean operating time of 3 hours. My mean operating time, my experience, was an hour and a half to 2 hours, but most of the patients were much smaller and younger, and therefore easier, and had a lesser operating time as we ended up operating on Zayan. But the operation takes as long as it takes.
Professor Beale, Ms. Baele said that she accompanied Zayan into the theatre while he was anaesthetized. Do you recall that?
I do recall that.
And did you go into the theatre with Zayan whilst he was being anaesthetized?
Not immediately, no. I did go in. I did follow into theatre, but I think he was already anaesthetized and intubated at that stage. And then it was a matter of of preparing, positioning him, setting up the necessary screens and apparatuses that were going to be used, and then the nursing staff would prep the patient with the skin, the antiseptic solutions, and then the drapes would be laid, giving you exposure to the area that you needed to access. And then in this sort of case, there's a face screen across, separating the anesthetic area from the surgical area. There's a sort of right angle structure across, and then the drapes are draped over that. So you don't have a particularly full view of what the anaesthetist is doing, and the television screen that you're going to be concentrating on is above that level, and it requires intense concentration throughout the duration of this kind of operation.
Professor Beale, two things I just need to take up with you on that explanation. You've explained what needs to be done in order to ready the patient for the surgical procedure. Is there therefore a difference between the time that a patient spends in theatre and the time that the operation takes?
Yes, there's so-called anesthetic time, which is the induction of anesthesia and preparation for surgery, and then incision time is when you actually start the procedure.
My Lord, I don't need to take the witness to it, but because it's in the records already, but can I give your Lordship the reference? It's in Exhibit J at page 3-447. And that's the page that records theatre time starting at 14:45 and incision time at 15:20.
Which is about 35 minutes later.
That's correct. Professor Beale, you've described the layout of the theatre. In preparation for your evidence, you have prepared a schematic layout of the theatre. Is that correct?
Yes, my Lord.
Yes. Well, I beg leave to hand that up. ZZQ, Lord, Zulu Zulu Quebec.
Any objection?
No objection.
Thank you.
Is that you received?
Professor Beale, do you confirm that ZZQ represents the layout of the theatre as it was when Zayan was operated?
Yes.
And
I've got an extra copy, which I don't need.
just to identify different people, on the left-hand side of the page with the label surgeon, is that yourself, Doctor?
Correct.
Yes. On the right-hand side of the page with the label assistant, that's Dr. Eugenie Elliott.
Correct.
And the anaesthetist chair, is that where Dr. Munshi would have sat?
Yes.
Yes. And you referred to a screen and drapes. Would you point that out to His Lordship?
There's a screen that you see towards the upper end of the table, which is a metal rod across. It's anchored onto the side of the table. The mobile thing, you can adjustable rod, and the drapes cover that, so you have access to the abdomen, but it's separated from that part of the operating room.
Can you give His Lordship some indication of how high that screen is off the bed?
Probably 30 centimeters or so.
The anesthetic machine, does it have a screen on it?
No. In the diagram, I think the assistant is a bit higher than they usually are.
The TV screen that is indicated on the right-hand side of the page,
Yes.
is that the screen that you look at whilst performing the surgery?
Yes. That maybe comes a little way around, sort of between the anaesthetist and the table, and the assistant will be a little bit more to the lower, the mid section, midpoint of the table.
And Professor Beale, just one last thing, to orientate Zayan on the table. His head would be towards the anesthetic machine side, and his feet would be towards the instrument table side. Is that
Correct.
My Lord, I see it as 1 o'clock.
Let's take a lunch break. We shall proceed at 2. Correct?
Thank you.
Class will put some bit of up, LED, lights back. Let's do what we have left in terms of time. Mr. Beale, I remind you are still under oath.
Yes, madam.
Mr. Green,
Thank you, my Lord.
your witness.
Professor Beale, before the lunch adjournment, you gave evidence on Exhibit ZZQ, which is the schematic layout of the operating room. Could you tell His Lordship, does the anaesthetist have a screen where he can see the readouts of that which he is monitoring?
Yes, madam.
And are you able to see that the results of what are being displayed on that screen of the anaesthetist?
Not under these circumstances, no.
Dr. Elliott has given her evidence about being your assistant. Had she acted as your assistant on previous operations?
Limited number, 2.
And what is Dr. Elliott's role as the assistant surgeon?
In a laparoscopic operation, the main role is to hold and steadily direct the camera lens.
Does she hold the Nathanson retractor?
No, that's fixed on a clamp.
She is, as I understand it, an extra pair of hands for you if you need them.
She served with a group called Helping Hands, extra helping hands that you could call upon for assistance.
Could we then turn to the operative procedure that was performed on Zayan? Was that procedure complicated or uncomplicated?
It was uncomplicated, it just took longer than average.
Yes. Could you tell His Lordship what the main factors were that made the surgery take longer?
Main factor was the degree of obesity or overweight status of the patient, in that the abdominal wall was particularly thick, and secondly, so the operating space within the abdomen was smaller, and in addition there was fat deposits within around the organs and within the mesentery. So you had to work carefully in order to do a bloodless dissection, which is done with an harmonic scalpel.
The fat that you have referred to around the organs, is that different to subcutaneous fat?
Well, in terms of its distribution, yes.
Tell His Lordship about the positioning or repositioning of the liver. Did that in any way delay you?
Not really. It's not unusual to have to loosen and reposition the Nathanson retractor on a couple of more occasions during the course of an operation like this.
Did Zayan remain in the same position throughout the operation?
Yes, I think after he was positioned in the head-up anti-Trendelenburg position, I don't remember. There was an occasion when the anaesthetist said that the oxygen saturation had gone down, the pulse rate had gone up, and where we interrupted the insufflation of the abdomen and removed the instruments, and whether the patient's position was moved at that time or not, I'm not sure. He might have been put flat rather than in head up, but that's just a matter of adjusting the table.
Just on that, the anaesthetist asking you to pause the operation, can you give His Lordship some indication of timing? As best as you can recall, how long had the operation been underway when the anaesthetist made that request?
About an hour, 15 minutes.
And just to be clear, what do you recall the anaesthetist saying to you at the time?
Exactly what I've said, that oxygen levels had decreased and the pulse rate had gone up.
That's just what is there something else?
Sorry, Mum, I wanted to interrupt by nothing.
So I heard before that, right?
No, Mum.
Now, Dr. Munshi says to you the oxygen saturations are down and the pulse rate has gone up. What did he ask you to do as a result of that?
To pause the surgery.
And what did you do in response to that request to pause?
Reverse the insufflation and remove the instruments from the abdomen.
And did you then see what Dr. Munshi did?
Not that I really recollect. He fiddled with his side of what was going on, and I think that he might have increased the ventilatory pressures.
The operation proceeded, we know that. How did it come about that the operative procedure resumed after Dr. Munshi had asked for it to be paused?
The pause period was not particularly long. I don't think more than 5, perhaps 10 minutes at the most. And then he said he was satisfied and we should carry on.
From that point onwards until the end of the operation, did Dr. Munshi indicate to you again that the surgery should be paused?
No,
Did you become aware of anything in respect of Zayan's condition that was untoward from
No.
that point onwards until the end of the surgery?
no, I proceeded as rapidly as conveniently possible in order to get the procedure completed.
Dr. Elliott said that, in her recollection, Dr. Munshi had said towards the end of the procedure that he suspected a pneumothorax. Did you hear Dr. Munshi say that?
No, not at all.
And would you then have a look at Exhibit ZZQ, which is the layout of the operative theatre? Just to confirm, Dr. Elliott would have been seated at that place more or less marked assistant. Is that right?
Yes,
And Dr. Munshi would have been seated more or less at that place marked anaesthetist chair.
yes.
When you had completed the operation, this shouldn't be contentious, you removed the insufflation, removed your instruments, and sutured the
Small
incision site.
incisions, yes.
Who is responsible for extubating a patient after surgery has been completed?
The anaesthetist does that.
Who is responsible for reversing the anesthetic?
Likewise, the anaesthetist.
And who is it that is responsible for taking the patient to a recovery room to ensure that they wake up from anesthetic?
The anaesthetist.
Do you recall if you left the theatre before Dr. Munshi had commenced the reversal of anesthesia?
I did.
And when you left the theatre, what did you then do?
I went to speak to the parents.
Could you just tell His Lordship what you told the parents?
I told the parents, Mr. and Mrs. Zayed, that the operation had gone well. We achieved what we wanted to achieve. And Mrs. Zayed asked me why it took longer. And I said, well, because he was tended to be overweight. And secondly, because I wanted to be very thorough and make sure that there was no further spewing.
Do you recall where that discussion took place?
Yes, at the entrance to the reception area for the theatre.
And once you had spoken to Mr. and Mrs. Syed, where did you then go?
I went to the recovery room.
And what did you see when you arrived at the recovery room?
I saw that the anaesthetist was with Zayan, the patient, and he was checking Zayan out, listening to his chest amongst other things. And Zayan had only one monitor on, which was the oximeter. And I asked him if everything was okay.
Just the him? Who is him?
The anaesthetist,
Dr. Munshi.
Dr. Munshi, yes.
Okay, sorry, I interrupted.
And no, not at all. And he said yes, he was stable, and his O2 was 93. Told me at the time, but he said there was decreased air entry on the left side, and he wanted to have a chest X-ray done. And he discussed the differential diagnosis, whether it might be a a pneumothorax or whether it might be atelectasis of the left lung, and he wanted to differentiate that. So I said to him, okay, I will wait in the tea room until the x-ray is done. And then he said I didn't need to do that. I could leave. He sort of persuaded me to leave and said that there was a pneumothorax. He'd handled them many times in his training at Baragwanath. And I almost reluctantly and regretfully left.
So, Professor Beale, just speak up. Your voice is trailing off.
I reluctantly and perhaps regretfully left.
Professor Beale, the microphone doesn't amplify. Just raise your voice.
Okay. I left and I told him that I lived only 10 minutes away, and that if he needed, if Zoun needed a drain, if he needed any help, he would just call me and I will come back straight away. And in fact, I'd only just got to the entrance of where I live when there was a call from Mrs. Syed, Miss Valley.
I'm going to interrupt you again,
yes,
because we need to do things in a chronological order. When you have that discussion with Dr. Munshi in the recovery room that you've just recounted, do you know if Mr. or Mrs. Syed was present?
Not to my knowledge.
Dr. Munshi has told you that there are decreased breath sounds, and you have a discussion about the differential, and that an x-ray has been called for. At that stage, did you consider Zayan's condition to be serious, one of concern, or was he stable and in a loosely an okay condition?
Yeah, he was stable and he was in a controlled condition, and reassured by Dr. Munshi.
And his lordship has heard lots of evidence about how to treat a pneumothorax, and that it is the insertion of an intercostal chest drain which normally results in a very quick and rapid resolution of a pneumothorax. Do you confirm that was your understanding as well?
Yes, there's an easier interim way, and that's just to put a needle, for instance, an IV needle of the appropriate size into the chest cavity and blow off the pneumothorax, which takes a few seconds.
And Professor Beale, when I interrupted you and took you back a little bit, you were telling his lordship about a telephone call that you received before you parked. Would you pick it up from there?
Certainly. I just got into the entrance of where I stay when I received a call from Mrs. Syed to say that things were not going well. And I said, okay, I'll come back now. And I turned around and I went back. And in those 10 minutes that it took me to get back, she phoned me twice. And I reassured her that I was on my way. And I think the second time I was just at the entrance of the Park Lane parking. And I went to the recovery room. And by this time, Dr. Munshi had placed an intercostal drain on the left side, and it appeared to be bubbling okay. But Zayan hadn't sort of recovered as one would expect a patient to recover after drainage of a pneumothorax. The x-ray had been done, and I viewed the x-ray, and there was a pneumothorax on the left side with a degree of tension. Not huge tension, but a degree of tension. So the first thing I did was to place a second intercostal drain, because that's the routine. If the first one doesn't appear to have had the required response, put in a second one. That bubbled a little bit, but so at the autopsy it was shown that both intercostal drains were in the pleural cavity.
Let me just stop before we go too far. You've referred to the drains bubbling. Could you just explain to His Lordship what it is that you're describing?
Well, you're putting a pipe in through the chest wall, anchoring it at the insertion site in the skin, and this goes into what we know call an underwater drain set. So it's a non-return valve. So when the patient breathes in, it doesn't suck air back into the lung, into the pleural cavity through the drainage pipe. But any gas in the pleural cavity escapes through the chest and bubbles through the water of the underwater drain. And clearly, you know, whatever gas had been in the chest, and under these circumstances, it's most likely a capnothorax rather than a pneumothorax, which is carbon dioxide, which it, in any rate, resorbs on its own. So, you know, we were then at that stage, and then Dr. Khan phoned me.
Okay.
Okay.
Go slowly with me, please, Professor Beale. You have referred to looking at an X-ray and that it had showed a degree of tension.
Correct.
Would you tell His Lordship when the first time was that you knew there was a tension pneumothorax?
That was the first time that I was aware of that.
What is that? You said that. Tell His Lordship what that is.
The tension pneumothorax. No.
You're looking at time. You said
The time.
that is when you first know. When is it? What?
On my return to the clinic and the recovery room, because Zion was still there.
It's been suggested by Mr. and Mrs. Syed that there was discussions of a tension pneumothorax before you left the hospital to go home. What do you say to that?
That's incorrect.
I again interrupted you. You inserted the second intercostal drain. Did Zayan recover when you inserted the second intercostal drain as you expected?
There was no dramatic recovery, no.
And tell His Lordship what you then did.
Well, it was at this stage that Dr. Munshi said that he wanted to re-intubate Zayan. And he didn't have a cardiac monitor on his chest. I put a cardiac monitor on. You would have expected the nursing staff to do that, but and then Dr. Munshi did re-intubate. I was standing on the left side at the head of the bed, and Zayan cardiac arrested at that moment. And you know, with no delay whatsoever, I started external cardiac massage, and he was ventilating with an ambu bag.
Is he being Dr. Munshi?
Yes.
Doctors use a terminology of somebody was running the resuscitation. That's a terminology used to describe the doctor who is in charge and directing the resuscitation. If that is so, who was running the resuscitation of Zayn?
Well, Dr. Munshi was.
You then, a moment ago in your evidence, referred to Dr. Khan. Could you tell His Lordship what you recall of Dr. Khan?
Miss Baele had phoned Dr. Khan and told him there was a problem, and he phoned me and said, "Is there a problem? Is everything okay?" I said, "No, it's not okay. You come to the hospital." And he did. So he must have arrived 15 minutes later.
To your recollection, did Dr. Khan participate in the resuscitation?
He did. He did. Did, my lord. You know, he suggested we put a second drain in, and he had to be told that it had already been done. And he gave intravenous fluids, and I'd already put in a left subclavian central venous line for easy access to administer medications and fluid, and so the rest of the resuscitation was really left to Dr. Munchi and Dr. Khan. The next person who arrived there was Dr. Kassel, but he didn't participate at all. And I'd actually made provision for Zayon to go to the ICU on that same level, which is an adult ICU. That Zayon weighed 53 kilograms, and he was a large 10-year-old, and he was admitted to that ICU and accepted at that ICU.
Can I just interrupt you again? Do you recall Dr. Muller being present?
And Dr. Muller was the next person to arrive.
Tell His Lordship what you recall of Dr. Muller?
Well, Dr. Muller came and also participated, and he then transferred Zayon from the recovery room to his ICU. And resuscitation continued there, and as I said, the response and recovery was not in keeping with what one expected.
Can I just interrupt you again, Professor Beale? I'm sorry. In the ICU, are you involved in the resuscitation, or is that dealt with by other doctors?
I was not heavily involved, but I did intermittently help with external cardiac massage.
Carry on.
And this carried on, and I think quite a large amount of intravenous adrenaline was given and other medications, and I couldn't say exactly what was given. And eventually, a couple of hours later, the resuscitation was not sustained. Initially, after initial cardiac arrest, we got a heartbeat and a sinus rhythm back. And as Dr. Khan testified, the rhythm seemed to be fine, and the blood pressure and the oxygenation recovered. But then Zayon had an arrhythmia, and he started deteriorating and going backwards. And unfortunately, that was a progressive thing that happened.
And we know that Zayon passed away later that evening. Once he had passed away, what did you do?
Well, parents were very upset. Mrs. Baele was lying on the floor and whatever. I tried to be sympathetic towards her, not receptive to anything actually, but and the people from the Muslim post-autopsy organization arrived, and he knew who I was, and he spoke to me. And then the people who were around there started dispersing, and what I did was I filled in the forms relating to what had happened, and which the police and the post-mortem people required.
And His Lordship has seen those forms that you filled in. So those were filled in on the evening.
They were, because it was urgent that a Muslim autopsy was done. And it was very upsetting and tragic and unexpected. I left and went home.
Professor Beale, that's then what we need to tell His Lordship in respect of Zay and Syed. So we now need to switch gears, as it were, and move to Ethan Tubes. So we can just move on to that. Now,
Yes, sir.
Ethan passed away in April of 2012, so that is 12 years ago. And could you tell His Lordship, do you have a clear recollection of all of the events or not?
I think my recollection is not bad because tragic events like this are indelibly imprinted on one's mind. But there will be things that I don't recall completely.
Do you have access to your patient file and notes that you may have prepared when you treated Ethan?
I don't have those original files and notes. I think they were stolen in a hijacking, and I still had them at the time that we prepared for a hearing at the HPCSA on the same matter, but I don't have them anymore.
Did you say they were stolen? Did I miss something? Did you suggest they were stolen? The notes were stolen?
It may have been that they were stolen because I had a hijacking, and my car and briefcase in the back and so on were all stolen.
And so, Professor Beale, just to help His Lordship, you can't find the files. You're not sure, but they may have been part of that which was taken from you during the hijacking. Is that?
That may be where they went, but I don't have them anymore. And they were around at the time of the HPCSA hearing, but I don't have them now.
Well, there are bits that allow one to piece together what happened. You first saw Ethan on the 29th of February 2012. Could you tell His Lordship where your rooms were at the Park Lane were in February 2012?
I'd not moved into the main hospital at that stage. My consulting room was still across the road, the lower ground floor of the consulting building there. And I also used those rooms on a seasonal basis. And the Tuber's family came to see me there.
And just to make a point, it's a different consulting room to where you saw Zayn.
It is.
Now, at that consultation on the 29th of February, do you recall who was present?
Yes, I do.
Tell
very
His
well.
Lordship.
Well, Mrs. and Mr. Tubers and the twins. Ethan himself and his twin brother called Liam.
Is there any significance to Liam, the twin brother, being present at the consultation?
I think he was a natural comparative study as to the difference between the two twins.
And just generally, just tell His Lordship what your observation was when comparing Ethan and Liam.
Well, Liam was clearly more robust and bigger and heavier than Ethan, and also had a better colour than Ethan did. Ethan was paler than his twin brother.
Do you recall whether you received a referral note from Mrs. Tubes when you consulted with her?
I think not. The process of them coming to see me was that Ethan had been seen at Waterfall Clinic on a weekend, on a Sunday, I think, by a general surgeon in pain and with a very distended abdomen. And he was seen by a general surgeon called Dr. Baele, I think. And Dr. Baele was concerned that his history and symptoms may be in keeping with with Hirschsprung's disease, and he had then organized for a subsequent barium enema. The barium enema has shown a caliber difference, or what we would call a transitional zone, between distal narrow bowel and proximal more dilated rectosigmoid.
I'm going to interrupt you again, Professor Beale. For the same reason, I need to get some things to His Lordship. During the consultation on the 29th of February, do you recall who it was that did the talking in the consultation from Mr. and Mrs. Tubes?
Mrs. Tubes was by far the more dominant partner and did all the talking, and Mr. Tubes was in the background, sort of taking care of the two twins.
Did Mrs. Tubes give you a general medical history of them?
She did.
Recall what the points were that she
Yes,
told
I
you?
mean, from their birth at the Santon Clinic, where they were born, I think both sort of very similar weight of 1,200 grams as low birth weight twins. And they had spent several months, I think, in hospital before they went home, cared for by Dr. Michael Greef. And they were doing okay, and what became apparent, especially from the age of 18 months, that Ethan was very constipated. Whether it was present but less prominent prior to that, I'm not sure. But he was progressively more constipated, became distended. He was miserable, unhappy. He was behind his twin brother in growth and development. In fact, Liam was 2 kilograms heavier than Ethan at the time. And Ethan was, I think, on the growth charts that I checked at the time, was about the 8th to 10th percentile. So it was a history of chronic constipation and inadequate growth and development in comparison with his twin brother.
Did Mrs. Tubes mention any conservative treatments for constipation?
Oh yes, he'd been on every kind of conservative treatment for his constipation in terms of syrups and Pegicol enemas and everything that was available on the market.
You have then, earlier before I stopped you, you referred to a barium enema that was ordered by Dr. Baele. Were you given a copy of the report of the barium enema?
I was, and
I just
think I might have seen an image of the enema as well.
I just put the report before you. In order to an exhibit ZC, and that's at page 3-877. Professor Beale, is that document which one sees at page 3-877, is that the report of the barium enema?
Dr. Gavin?
Yes.
Sir. Right.
Is that what you...
That's correct.
Yes. And the assessment reads, findings are suspicious for Hirschsprung's disease. could you tell his lordship whether your clinical observations were consistent with possible Hirschsprung's disease or not?
They certainly were sort of fairly typical of Hirschsprung's disease. You know, you can have frank bowel obstruction as a newborn if it's a long segment Hirschsprung's disease. Lesser degrees would present this way, the way Ethan presented. And the X-ray finding is also consistent with that sort of functional obstruction.
Now, Professor Beale, just bear with me, keep your eye on me, because I, again, got to get some things to his lordship. The X-ray which you have referred to, did you receive a report of the X-ray?
Yes.
My Lord, that's not yet before your lordship. I beg leave to hand it up as the next exhibit. It will be ZZR.
No objection, Madam.
Professor Beale, this exhibit ZZR, the report of the X-ray report that was made available to you at the consultation.
Yes, just on a plain X-ray,
Yes.
without contrast.
And it records fecal loading with no bowel obstruction or free gas. Was that consistent with possible Hirschsprung's disease or not?
Yeah, it's very non-specific, but it could be in keeping.
Just generally, can you tell his lordship what the clinical presentation of Hirschsprung's disease is in a young child?
Well, there's a fairly wide range of presentations, from complete bowel obstruction in the newborn, delayed passage of meconium, which will occur in some patients, not all. And otherwise, it may be a later onset of constipation. And, you know, one sees most Hirschsprung's disease in early infancy and in the toddler period, but I've seen it in teenage people and even adults. And it's progressive, it's intractable constipation, discomfort, abdominal distension, and and in infants and toddlers, delayed development.
Professor Beale, still sticking with the consultation on the 29th of February 2012, you've explained to his lordship the history that was given to you by Mrs. Tubes. Did you examine Ethan?
I did.
Can you tell his lordship what you can recall of that examination?
Well, the pertinent features were that Ethan was small for his age, and secondly that he had a gaseous distension of his abdomen, and suggesting that it was chronic was the fact that he had a widened subcostal angle, which is the degree of displacement of the ribs on each side being wider rather than narrower.
See if I can get the lawyer explanation of that. If one
Yes.
puts your hands against your ribs, they form an angle, a V pointing up.
Yes,
And when you say a widened subcostal angle, you suggest that the hands would be relatively more horizontal than vertical, resulting
Correct.
in a wider angle. Is that correct?
correct.
What else can you recall of your clinical examination?
Well, that's about all. And Ethan was pretty restless, not that easy to examine. Palpated his abdomen. It was just a bit of gaseous distension, really. I withheld doing a rectal examination because we were going to recommend a rectal biopsy, and I would have the opportunity to do a rectal examination under anesthetic, which is preferable to doing one on a wake toddler.
And is there anything else in the examination?
I think not.
Did you then have a discussion with Mr. and Mrs. Tubes?
Certainly with Mrs. Tubes.
Tell His Lordship what you can recall of that.
Well, I told her that his features were in keeping with the possibility of Hirschsprung's disease, but certainly in our environment one doesn't diagnose or proceed with treatment without a biopsy. And I can tell you in some parts of the world that does happen, but he needed a biopsy to get a definitive diagnosis of what was going on.
Did you explain to Mrs. Tubes what Hirschsprung's disease is?
Well, it's an absence of nerve cells for a variable extent above the anal rectum in the rectum or the rectosigmoid, in short segment Hirschsprung's disease.
You'll just listen to my question. It's, did you explain to Mrs. Tubes what Hirschsprung's disease is?
I did.
Did you form an impression of Mrs. Tubes' state of knowledge about Hirschsprung's disease during that consultation?
I did.
And just tell His Lordship what your impression was.
My impression was that she had researched the matter and the condition, and she was fairly well informed.
Did you explain to Mrs. Tubes what the treatment is for Hirschsprung's disease?
I did. But
Can you tell His Lordship
after
what you can
a
recall
biopsy.
of that explanation?
that's what segment Hirschsprung's disease is treated through the anus. One doesn't open the abdomen. And it's a transanal resection and endorectal pull-through, which is a relatively minor procedure because it's done through the perineum, through the anus. One doesn't open the abdomen. And it's a very successful and safe procedure in a very high percentage of cases.
Did you explain any risks of that may be involved in the procedure to Mrs. Tubes?
I did. I don't know whether she requested them or whether I just volunteered them, but I told them that very, very seldom you might get a leakage. Could get infection, and there shouldn't be any other risks. You know, it's also dependent on whether you take sufficient length of bowel to a level of bowel that's going to function normally. And what we do is get an intraoperative, what's called a frozen section biopsy, checked by a pathologist.
We will come to the frozen sections and the performing of the pull-through in a short while. Did you explain to Mrs. Tubes what the biopsy procedure involves?
I did.
Would you just explain to His Lordship what the biopsy procedure involves?
There are different ways of doing a biopsy, but what we planned with Ethan, I think most biopsies in infants certainly are suction rectal biopsies, which is done with an instrument that sucks mucosa and submucosa, but Ethan was an older toddler and we planned to do a full thickness incisional rectal biopsy, so you've got to put a little retractor into the anal rectum and then 1.5 centimeters above the dentate line, which is the transition between the rectal and anal, rectal mucosa and anal skin. You make a longitudinal incision and you excise an ellipse of tissue, or full thickness of the rectal wall. And at the time, you then close that incision with sutures.
And we know that the biopsy was performed on the 12th of March at the Linksfield clinic. That procedure that you've just described to His Lordship of taking the full thickness biopsy, is that the procedure you performed on Ethan?
It is.
Once you have the biopsy sample, what did you do with it?
Well, it goes into formalin and you fill in a request form to the laboratory and you send it to the laboratory that you use, which was in fact Lancet Laboratory, and you request examination looking for the possibility of Hirschsprung's disease.
And His Lordship has heard that Dr. Anita Gildenhuys was the person at Lancet that ultimately examined the specimen. Can you recall how you came to know it was Dr. Gildenhuys that was performing the analysis?
Well, Mrs. Tubes was very keen to know what the outcome was, and she'd already phoned me fairly early on the second or third day, and I phoned Lancet, and what you got to do is find out who the person is who is examining the specimen. And I was told it was Anita Gildenhuys, somebody that I knew quite well.
But where do you know Dr. Gildenhuys from?
Well, she was with the Institute of Pathology in Johannesburg Hospital with Wits University, and then I knew she was subsequently at Lancet and that she was a specialist in pediatric biopsy specimens.
Did you telephone Dr. Gildenhuys?
Yes, I did.
Now, it's 12 years ago. Can you tell His Lordship what you can recall of the telephone calls, and if there's more than one?
I think the first time I called her, she hadn't.
Professor Bill, let me just finish the question. And can I ask you to take the answer up to the 16th of March? And that's when Mrs. Tube says that she has a call with you. So if you'll just use between the 12th of March and the 16th of March. Do you recall any calls there?
The first time I called Anita Gildenhuys, she had not completed a examination of the specimen. You know, it's a process in which they stain the specimen with specific stains, and then they fix it and they take sections of it, and so then there's a microscopic examination.
I can see that Mrs. Rose basically leaning forward to try and pick up what you're saying. And I suggest the trailing of the situation, try and pick up the voice again.
Thank you. I'm sorry, my apologies.
Professor
The
Bill,
long day I understand it's a bit warm, it's a bit hot, and I can understand. But just try. We are just a few minutes away from, a journey for the day. Just try and maintain the momentum.
And the first time she had not completed an examination, and I phoned her again a couple of days later, and she told me that she had examined the tissue, and she'd done a pretty extensive examination, and she'd seen no ganglion cells at all, and it sounded like she didn't expect to see any, but she said she would do further sections of deeper layers and so on, which she subsequently did.
now, Mrs. Tubes gave evidence that she spoke to you on the 16th of March 2012, which is a Friday. Did you speak to Mrs. Tubes?
I did.
Yes. And what do you recall what you told her?
I told her on the examination so far there had been no ganglion cells seen. And the pathologists seem to be fairly sure about that, but they do additional levels.
Do you recall during that conversation on the 16th of March whether you suggested that certain medication should be prescribed to you?
I don't recall that, no.
Let me show you, if I may, an email that Mrs. Tube sent, and my Lord, it's not yet before you. I beg leave to hand it up. Lord, and it's Exhibit ZZS.
Any objection?
No objection.
Now, Professor Beale, this is Exhibit ZZS is an email which Mrs. Tube sent on the 19th of March, which is Monday, 2012, and it's to Dr. Mohammed. And it says, following Ethan Tube's barium enema and biopsy last Monday, he's been diagnosed with Hirschsprung's. Please can you arrange a script for Ethan for Pegicol sachets? He now has to take 2 sachets per day until his operation with Professor Beale towards the end of next week, so I need quite a quantity. Professor Beale upped the quantity he has to take via his cell phone on Friday, but unfortunately cannot arrange the script for me as he is away on Congress. Professor Beale, do you accept that Ms. Tubes is correct in saying that you upped the Pegicol?
I don't recall this, but I wouldn't contest it. I'm sure that if she said that, then it's correct.
Professor Beale, in preparation for your evidence, you have searched your records to see if you could identify which Congress it is that you were away on. Is that correct?
I did.
And were you able to find anything in those 12-year-old records?
With the rest of records of Ethan Tubes, my diary for that year is no longer around and available, and I don't recall at this stage, 12 years down the line, what Congress it was where.
Professor Beale, just to round this out before it's the end of the day, could I ask you to take the exhibits, and it is in Exhibit C at page 3-104. Mr. Boyce will help. And it's Dr. Geldenhuys's report. C, my lord, 3-104.
Starting this one. Thank you.
That is my lord. Professor Beale, do you recall when you spoke to Mrs. Tubes on Friday the 16th of March, had you seen Dr. Gildenhuys's report, which is before you?
No, I hadn't. I just had a telephonic communication with him.
Would you look at the report, which is at page 3-104? It identifies addresses to where it is sent. The first one is to the Joburg General Hospital Area 155. On the right-hand side it says Other Doctors. Copy Linksfield Infection Control. Copy Linksfield Paediatrics.
Correct.
With those addresses, are you able to offer to His Lordship a possible explanation for why you had not seen the report by the 16th of March?
Well, Linksfield Clinic's a place I was only going sort of essentially once a week, unless I had an inpatient there. Otherwise, Johannesburg Hospital had an office there. The delivery of reports was not that reliable.
Delivery of the reports?
Hmm?
Let's pick up your voice. What about the delivery of the reports?
Yeah, the delivery of the report is not that regular and reliable. So I hadn't seen this report, and also there's the story of my having been away at a congress, which I don't have a recollection of. So I would have seen this report later on, after my return or whenever. Anyway, when I did see it,
Professor Beale, I need to interrupt you there. Lord, it is the finishing time now, and this next bit that we need to move to with Professor Beale should be dealt with as a single chunk without interruption.
Fair enough. Are you driving this particular exhibit?
Yes, ma'am.
It's been a long day, no interruptions. I think it's unfortunate for us to attend tomorrow. Tomorrow it's a Friday, it's going to be a short day. For amongst other reasons, the league here was given as another serious committee, meaning that by 11:30 we have to adjourn. So may I suggest that we should start at 9:30 instead, to try to make up time. Is that in order?
My Lord, of course, could I just draw to your Lordship's attention, I have to argue a leave to appeal tomorrow. I've imposed on the judge hearing that to start at 8:30, and my prediction, which I hope is correct, is that leave should be granted in the first 2 minutes. So I should be here on time, my Lord, but if I'm a minute or two late after 9:30, if you would bear with me.
Application for leave usually take 30 minutes and not more. We're talking about the usual practice of investigation, which your counsel will know. So if you're starting at 30, by all means, I don't think 9:30 should be proper.
And get
But
into
in
your
the
Lordship.
event we can go on, taking note of what counsel said. Mrs. Leroux, any issue?
No.
9:30 tomorrow, don't forget, be here by 9:30. Mr. Beale, do you have the time?
yes,
9:30.
yes, my lord, I'll be here.
9:30.
Yes.
Thank you. We are
Thank you.
All right.
Can you please raise your right hand and say so help me God?
So help me God.